So running through just a little bit about myself, for those who aren't aware, I'm immediate past president of our Breast Society in Australia, New Zealand, which is a peak body for breast surgeons. Lauren's run through relating to my involvement with the Institute of Academic Surgery and at Chris O'Brien Lifehouse. I'm also the Chief for Central for Breast Screen New South Wales and a consultant surgeon at Chris O'Brien Lifehouse and at RPA. So when it comes to assessment of the breast, to see if I can move, I'm seeing myself here. Basically, our approach to it is to triple assess any patient, whether they're pregnant or not. And this includes a full history exam, imaging in the form of ultrasound and mammogram where we can, and histological assessment via core biopsy. And we know that by triple assessing that we increase our accuracy over potentially not doing it, and we're likely to pick up, in most cases, any breast cancers. And there's a proportion that are medical legal cases where imaging is normal and there's still a lump, so hence the reason for histological assessment as well, where possible. In terms of the history, we think about a personal history of breast disease, a family history of breast and ovarian cancer, previous pregnancies are relevant, and whether there's any breastfeeding, and this is all comes down to hormonal interplay, and any medications that increase estrogen exposure. We like to know also around the history of breast trauma. And in terms of the symptoms, I think it's probably irrespective of pregnancy, but you're aware of the changes during pregnancy, and that includes a breast mass or lump, skin changes, nipple discharge. So it is important on inspection to also focus on the nipple and associated breast pain, nipple changes, which we mentioned, and breast or nipple asymmetry as well is something which is worth noting. And we're going to use a few cases to make it hopefully a little bit more interesting when we're talking about pathology. So the first lady and these are cases that we've seen, and a lot of them have been seen relatively recently. So the first case is a 32-year-old who's 6 weeks postpartum. She suffered from cracked nipples and struggling with latching, and this is not an uncommon scenario, and she ended up with worsening left breast erythema and was well systemically. On clinical examination, she had a tender region of induration of the medial aspect of the left breast with a palpable left axillary lymphadenopathy. And that's her photo. So she's now 6 weeks postpartum. She's systemically well and has a left lactational mastitis. And the GP performs the following baseline blood tests with a white cell demonstrating a slight rise in CRP up. And she was prescribed appropriately Keflex, 500 milligrams 4 times a day for 5 days. What we're looking for is gram-positive cover in that early coverage. And the patient was advised to return after an ultrasound in 24 to 48 hours. So she then proceeded to an ultrasound, which demonstrated a significant collection. It was 6.5 centimetres with echogenic debris, loculations, and an associated vascular ring, which you'd expect, which are breast changes with an infection. So where do we go from here? Like, she's got a reasonable collection. She's not unwell systemically. What now? And it is a tough one. It's very likely in this scenario, it's not going to be a cancer. Common things are common. It's very likely it's a lactational mastitis, and her imaging is correlating. It's not a solid component. It's likely pus in there, essentially based on her imaging. So I think this is a sort of lady that potentially would be appropriate for referral, but part of that approach will potentially either be Just based on size, she's likely to need intravenous antibiotics based on the size of that lump. And she will require an aspiration as well. So organising the aspiration is something that could potentially be done. But once you're getting up to a really large site, it is probably the time to phone a friend to try and assist with it. But the fact that she's not systemically well bodes well for her. So in terms of what we did for the patient, we admitted the patient to hospital, and despite the systemic stability, and started her on intravenous Fluclox, 1 gram 4 times a day. We engaged lactational consultant and encouraged the patient to continue expressing from the affected breast. And we performed serial aspirations. The first one demonstrated 26 mils of purulent fluid, and radiology, who drained it, recommended a further aspiration be performed, with it likely accumulating. And not surprisingly, she grew Staph aureus, which was sensitive to Fluclox and Keflex and clindamycin. We tend to use surgery as a backup option. And there are times when we do operate, and that's when there appears to be compromise of the skin. If on aspiration we are noting that they aren't aspirating a lot, there are times when I would potentially operate. I think it is important for us as surgeons to communicate with radiology around how well the aspiration's gone. We sort of need each other, so that communication has to be strong for the patient. So our second case is a galactocele, and so it's a 24-year-old female in her first pregnancy. She's 7 weeks pregnant. She discovers a 2-week history of a lump in the upper outer quadrant with no red flag symptoms and no family history of breast or ovarian cancer. And that's it. We've gone through the symptoms before. So in her upper outer quadrant, she has a 2-centimetre mass. It's smooth, well circumscribed, with no other masses and no axillary lymphadenopathy. And I'm hoping you guys can see that. So that's the lesion there. So with the galactocele, which this is, ultrasound appearances can be variable. It can be cystic or multicystic, and sometimes there can be an associated solid component. And with it being potentially solid, they're the ones that we definitely need to biopsy. But generally, as it presents as a lump, I think it's working. If there's any uncertainty, we tend to basically get a diagnosis because we end up with milky fluid. So essentially, it's a milk cyst, and our general treatment is they tend to settle spontaneously in the majority of cases, and really they aren't things that tend to get infected. If it's particularly bothersome, we repeatedly aspirate them to the lactating mother. And surgical excision, we have done it for refractory patients to aspiration or patients not wanting aspiration. The third case is a fibroadenoma, and this is a common, just gonna, so you can see it by myself. So she was a 28-year-old female that's recently been seen with an upper outer quadrant lump, similar sort of history. I guess the thing with this case is that it looks, compared to a cyst, what you note with solid things on ultrasound are that they tend to be more echogenic, and so they're not that black sort of color. They're not quite the same as the breast tissue. They're a little bit, they're in between. And the things that we're looking for on ultrasound are 6 characteristics to determine whether something's a benign versus a malignant lesion, which is what we're concerned about. And that includes whether it's taller than wide, so proportions, Acoustic shadowing is a common thing, irregular margins, disruption of tissue planes, and whether it looks smooth and well defined, and does it have a good capsule around it. So commonly, a lot of our fibroadenomas tend to meet 5 of the 6 characteristics, and a common characteristic missing is lobulations are present. And so if we do see it incidentally, what we tend to do is biopsy it, if we can feel it, but incidentally we'll make a call on if they've got multiple ones, which ones to biopsy. In this instance, with the lobulations appreciated, we've approached a biopsy, and the core biopsy has confirmed the fibroadenoma. So I guess for fibroadenomas by themselves, they are not concerning. But what the key is really identifying and proving that the lump that you're seeing as a surrogate for fibroadenoma on imaging is in fact that pathology. And imaging is good, but it's not perfect. So it's really working out whether or not that is a fibroadenoma. But for fibroadenomas generally, they're a stromal breast lesion. They don't significantly increase the risk of cancer for that patient if you proved it's a fibroadenoma. So if our baseline risk of breast cancer is 1, having a benign lesion such as a fibroadenoma increases the risk of breast cancer from 1 to 1.2 to 1.7 times. Whereas if you have an atypical lesion, that increases to 3 to 5 times. And so there's a significant difference between those 2 groups. And proliferative lesions, so fibroadenomas are non-proliferative breast changes in the breast. Proliferative changes include radial scars and papillomas. Their increased comparative risk for breast cancer is 1.7 to 2.1. So they themselves they're not precursors of breast cancer. They just act as surrogate indicators of increased risk with time. So for proliferative lesions that don't have atypia, and for fibroadenomas, if we prove they're fibroadenomas, our ongoing surveillance tends to be general surveillance rather than increasing to yearly. If we have atypical lesions is when we start to do yearly imaging. And in the setting of pregnancy, they don't compromise breastfeeding. They can be hormonally sensitive and grow quickly in pregnancy sometimes. And in those cases, we may tend to do something about them, but it's not common. So what are the reasons that we take out fibroadenomas? We tend to do it when the lesion hits a certain size. And why do we take them out at 3 centimeters? And it comes down to how confident are we that the biopsy we've done correlates the entire lesion. The larger they get, the more uncomfortable we are that that particular lesion is only that size, and hence a rationale for removing larger lesions. And our general cutoff tends to be 3 centimeters. If we tend to note rapid growth in the lump, despite a biopsy, we would tend to remove as well. And if they're causing pain is a common reason generally for removing them. In the setting of pregnancy, we tend to observe and do interval imaging to assess how they're going. And surgical excision generally, we tend to leave in the first trimester, and where we can, we'd probably hold off until delivery. So for this lady, surgery is scheduled 1 year following delivery after the patient has completed breastfeeding, and her histopathology confirmed a 2.3 centimeter fibroadenoma without any atypia. And we've followed up with an ultrasound in 6 months with no other suspicious lesions identified. So the next case is a case from this week that we've, in the last couple of weeks, we've been working up. She's a lovely 37-year-old, first pregnancy. She's 12 weeks gestation and has no symptoms of breast disease. She does have a strong family history with 2 paternal aunts diagnosed with breast cancer in their 50s. The sister was diagnosed with triple negative breast cancer, and the cancer genetics services were consulted, and there was genetic testing performed on a family, and the family members didn't have a gene mutation. So our patient KD was recommended to undergo screening ultrasound. She has a background of oral contraceptive use for 5 to 10 years and is a non-smoker. And this is a picture of her on clinical examination. The mark, I've outlined the size of the tumour clinically, with the surrounding mark representing probably with the associated margin we'd be looking for if we were to operate. So she's recapping, at 12 weeks gestation, she has a right breast upper outer quadrant lump. She has D-cup breasts with moderate ptosis, which is essentially a fancy word for the droop of the breast. And it's something that we take into consideration. And encouragingly, she has no axillary lymphadenopathy. So looking at her ultrasound, it's situated in the upper outer quadrant at 11 o'clock, 7 centimetres from the nipple, 2 centimetres in size, hypoechoic and irregular. And what you can see just based on that ultrasound, it's not regular, it's disrupting tissue planes, and it's not a black colour, which you'd see with a cyst. It's a bit lighter than that, which suggests a solid lesion. And so we've performed a core biopsy, and that's come back as a grade 3 invasive ductal carcinoma. Estrogen is 70% positive and HER2 negative. There's a marker called Ki-67 that we use a lot, and it's an immunohistochemistry marker. Generally, proliferation or Ki-67 above 20% is considered high, and this is sitting at 40%. She has focal high-grade precancer within the core biopsy as well. So when we talk about pregnancy-associated breast cancer, it's defined as a breast cancer that is diagnosed during pregnancy, in the first postpartum year, or any time during lactation. And it occurs in less than 5% of all breast cancers. It's pregnant women with breast cancer should be treated generally according to guidelines for non-pregnant patients, but there are obvious other things to consider with modifications to protect the fetus. And termination, it's something that we discussed early in pregnancy. It hasn't been demonstrated to improve outcomes, and it's something that would be taken on with the multidisciplinary group. So in terms of, for this lady, she's got 37, she's 37, she's in the first trimester, but fairly far along in the trimester. And so how do we investigate her? And what you've seen, we've performed a triple assessment, which was a history and exam. We've done a core biopsy. We performed an ultrasound. And at this point, the questions are, can we actually do a mammogram? Is that safe? She's got likely dense breasts. She's breastfeeding. Can we do an MRI? Is that safe? And so we'll address that. So relating to mammogram, a mammogram is safe in pregnancy. The ionizing radiation exposure to the fetus is less than 0.03 milligray, and teratogenic effects are concerning when above 50,000. So there's a significant difference there, and lead shielding reduces the risk by an additional 50%, which is what we would perform, what we would do. So to put this in perspective, the fetus is exposed to 1,000 milligray of background radiation during their normal development. And for her, this is her mammogram. So she undergoes a mammogram, and you're really not seeing, what you're seeing is a density in the upper outer quadrant, non-specific, but nothing in the rest of the breast. There is some denseness behind the nipple areola, but that's not looking particularly concerning. So obviously there's a reduction in sensitivity of a mammogram with increased glandular proliferation and in preparation for lactation. So relating to MRI, that's a separate topic. We probably would get extra information by an MRI, but in this instance, we're not able to use the GAD contrast, and the rationale for using MRI generally with breast lesions is it's a functional assessment of the breast, where the mammogram and ultrasound provides structural information. Mammograms, what they do is they give us whether or not there's calcium and densities, and ultrasounds demonstrate whether there are lesions we can see, which we've run through before. But with an MRI, really that enhancement of the lesion or functional assessment of it is very important. And because we can't use gadolinium, the rationale for doing it drops. There may be other rationales for doing MRs in pregnancy, but breast is not one of them. And the reason for that, it crosses the placenta and is a teratogenic substance. So in summary, we've done a history and exam, we've performed a core biopsy, we've done an ultrasound and a mammogram, but we didn't do an MRI for this patient. So then the question comes, she's at 12 weeks, she's got a grade 3 cancer, it's 2 centimeters on her imaging, it's clinically around the 3 centimeter mark, and she's at 12 weeks. What can and can't we do in pregnancy? What's the best order for her treatments for breast cancer? Are we able to preserve her baby? There's a lot of questions there. And so the smart thing for us at this point is to take her to a multidisciplinary meeting. And these are the options that could be given. Generally for breast lumps with breast cancers, we tend to start with surgery or chemotherapy. And a lot of the times when we talk about breast treatments now, we like to subdivide breast cancers into 3 types. There are those that are hormone positive, those that are HER2 positive, which is another receptor on the nucleus of the cancer, which has specific treatments. And the third group doesn't have a hormone receptor in the form of estrogen and progesterone or HER2 receptor. And for that group, we call them triple negative breast cancers. So for the HER2 positive and the triple negative group, our standard of care now tends to be giving chemo first. For the hormone positive group, it depends. Like the higher grade hormone patients, which we call luminal B breast cancers, we would tend to consider discussing, we'd get on the phone and speak to an oncologist, so it's not a captain's call, and then would make an assessment on the potential benefits. The potential likelihood of, if we were to give neoadjuvant or chemo first treatments to a HER2 positive cancer, we've got a greater than 50% chance of not having cancer at the time of operation. In a triple negative subgroup, that's at 30%. And it's important to recognize that the other 70%, 69% won't progress and will likely reduce on chemotherapy. Within the luminal B subtype, that drops to 18%. So there's a less than 20% chance that we're going to have complete resolution of the cancer by giving chemo first. In fact, it's probably not surprising because we haven't given any hormone treatment by that stage. But it sometimes buys time for the patient to think about their options. So this is our potential ways of managing this patient. And generally, we would want to it is important to realize that we can give chemotherapy in a pregnant patient. We don't do it in the first trimester, but from the second trimester, there are studies demonstrating with good data that it is safe from the second trimester on. And so any decision now will be put to our multidisciplinary group about sequencing of treatment. What I do know, she's got a 2 centimeter tumor. It's grade 3, hormone positive. She's going to need chemo at some point. The question is, do we give chemo first or do we operate first? And in fact, the timing, if we were to operate, she's at 12 weeks, she's likely to be okay for an operation now. We could potentially get on and do it quickly and then move on to chemo as well as another option for her. And so she was discussed at our multidisciplinary meeting. And the following recommendations were for upfront surgery. And then the next thing would be adjuvant chemotherapy prior to delivery. So, and then the timing would be pretty good if we can get on and operate for her to have her potential chemotherapy. The chemo that we give tends to run in now, it used to be 6 months, it tends to be 5 months with the AC or anthracycline component given every 2 weeks now, and there are 4 cycles of AC followed by 3 months of paclitaxel, which is weekly, 12 cycles. The way we're doing it now, in the pregnant scenario, rather than doing it every 3 weeks, the first group, we would, every 2 weeks, we would do it every 3 weeks, just to give a bit of a break, rather than doing the dose-dense AC, which is now standard of care. And then adjuvant radiation, we wouldn't do that in pregnancy. It's contraindicated. So we have to wait for pregnancy to finish to be able to give the radiation that she will require. So this is a picture from Tuesday this week, and this is the specimen we have taken out of the breast. If you look to your right, where I'm circling, there's a picture of our intraoperative X-ray, and you can see the dense lump there, and it's close on this margin here, so we've taken a little bit more. What we've done, because I really didn't want to come back for a re-excision for her, so put another anaesthetic for her. So we've taken a reasonable amount of tissue, and this is demonstrating on the left during the operation the probe we use to find the lymph node, which is basically technetium or a metal that gets trapped in the first node. And that's accurately picked up the node that we take out. Now, an important consideration is our standard of care for finding the sentinel node for patients who aren't pregnant is to use a blue dye and to use technetium. And we don't tend to use blue dye in pregnancy because of concerns during pregnancy, whereas the lymphoscintigraphy, we need to find the node somehow, and it's generally safe. So that would be our approach. So in terms of the operation then, we've taken out a large volume, as you've seen on the prior section, in the upper outer quadrant. All this has been cleared where a tumour is. And what we've done is we've rotated the volume from, which is just fat based on a few blood vessels running up, and we've rotated that volume to keep essentially her nipple areola in the middle of her breast mount. What will happen with the scarring, it will settle post-treatments, and with time, she will likely not see this scar. But importantly, despite taking a reasonably large volume out, we're able to neatly give her that volume back so that her breast still looks like a breast. And we call that a lateral intercostal artery perforator flap, which is a fancy name for a rotational local flap. So moving on to the next patient, I'm just thinking on that last patient, is there anything else that I can think of relating to pregnancy and how we have to adapt? So just the other things that will happen with her is that we will basically go from here. She's currently recovering. We'll see her next week to take the dressings off. She has a drain in situ, which will stay until there's less than 20 mils. She'll be having weekly ultrasounds through chemotherapy. She had a pre and post ultrasound of the baby, and that was done in conjunction with our obstetrics unit at RPA, and they will be heavily involved with her care through chemotherapy with weekly ultrasounds. So case 5, Mrs. E.T. This is a case of my colleague, Dr. Cindy Mack. She presents, and this is a recent case as well. She's a 34-year-old patient with 6 weeks history of a left upper outer quadrant enlarging mass. And she has whilst breastfeeding with a 10-month-old daughter. She's a busy mother of 3 with 3 children under the age of 4 and works as a manager of a childcare centre. And initially the patient was feeling this could potentially be a blocked duct and continues to massage this region weekly. And the palpable area is in that left outer quadrant, measuring 5 centimetres. Appropriately, the GP's coordinated for imaging in the form of a mammogram, ultrasound and core biopsy. The mammogram demonstrates 5 centimetre area of coarse pleomorphic calcifications in the upper outer quadrant. That sort of breast picture is a very dense breast, and we call that category D, which is the densest type of breasts. It's basically subdivided from category A to D based on what percentage of the breast is dense, 25% being A, greater than 75% being D, and a cutoff in between. So with regards to this area, what we can see is pleomorphic calcs. Hard to really see a lump because it's so dense, but on ultrasound, she has a 5 centimetre lump in the upper outer quadrant, and a biopsy demonstrates a triple negative cancer, which is estrogen receptor negative and HER2 negative. It's grade 3 and a proliferation of 60%. So as we discussed previously, this triple negative subtype is a type that's got a 30% chance of not having cancer at the time of operation if we give chemotherapy first. Coming back to that proliferation where we said 20% was high, this is at 60%. So this will respond likely very well to chemotherapy. So she was discussed at our multidisciplinary meeting at Lifehouse, and staging investigations were recommended. And we've moved away from so many CT chest abdomens and pelvis and bone scans. And it's due to changes in item numbers recently in the last year. We're tending to use PET-CT for advanced cancers and nodal involvement cancers. And we're fortunate to have a good PET person at RPA in the form of Professor Michael Fulham, who's been able to interpret these for us. And with regards to the other thing for her, because it's so dense, we're awaiting a breast MRI to see if that provides any more information outside of the ultrasound. And she's urgently been referred to medical oncology for consideration of neoadjuvant, which is chemo first. We commenced carbergeline to cease her lactation prior to chemotherapy. She was referred appropriately to the RPA fertility service, which is an important consideration for fertility preservation prior to chemotherapy. The patient is considering having a 4th child, and hence the discussions are important. She was also referred for genetics, and she qualifies for this with the aggressive biology of the tumour just by itself being now the increased criteria for testing includes being less than 50 and having a triple negative cancer, and that's only increased in the last couple of years. So that's basically where we are with that patient. So at present, we've run through 5 cases. They're all real patients and real scenarios. 2 of them are actually being seen very recently, and they're having ongoing care. What I'll do is I'll stop the sharing and look forward to any questions. I'm just looking at Effie. Do you want me to answer the questions on the Q&A?
I've tried to summarise them. There was a question about FNA in triple test, and does it have a role?
Yeah, that's a good question. I think generally it depends if it's cystic or solid. And depends on the state. We tend to prefer, I tend to prefer a core where we can, because it gives us more information. It obviously also depends on the type of lesion we're looking at. But if we've got a concern relating to a solid lesion, I tend to use a core. But there will be times when you've got very small lesions where there may be a role for it. Also, patients who are on blood thinners, it's often, another option we'd consider. But generally, the amount of information we get from a core biopsy gives us more information to an FNA.
Okay.
But a cyst is, it's a cystic lesion, coring it, you're just going to burst the cyst. So we're looking for solid components.
Case 1 about the abscess, people were asking about when would you do an outpatient drainage, when would you admit?
It's really hard. I think it's hard, and it seems to be an on the fence one. With that, that's like an end stage abscess per se, without systemic symptoms. I think you can manage generally patients with, if you've got the ability of a radiology service to appropriately aspirate an abscess and keep them from having to have a hospitalization, and it's systemically well, I think it's appropriate. If you are concerned relating to the degree of inability for it to resolve, resistance to treatments, or significant sized abscess, it isn't bad to consider, particularly if the aspiration isn't leading to resolution of it, to consider seeing whether a surgical import. And we do have outpatient settings as well. Relating to admissions is, we tend to do it for really large abscesses, and that was a large abscess, as everyone probably appreciates, and despite systemically being well, sorry. But generally it tends to be for those that have systemic symptoms where they're feeling unwell, they're not responding to oral antibiotics, and but it comes down, some people will be more comfortable just managing everything and have a lot of experience. Others, there's no harm if there are any concerns to consider appropriate referral. But basics would be oral gram-positive cover, antibiotics for most abscesses, aspiration with an ultrasound. And generally, if they're settling, hopefully you're able to manage it.
Okay. Case 3 with the fibroadenoma, there are a lot of questions about rapid growth, how often to ultrasound in follow-up, and phylloides tumours. Did you care to comment there?
Yeah, I think there are two aspects to the fibroadenoma. One is, are we sure that it's a fibroadenoma? And it's imaging's great, but it's not perfect. It's a surrogate for what their pathology is. And it can be very difficult for people who are managing patients who've got multiple fibroadenomas, varying sizes. How many do you biopsy? But if in the singular setting, it's probably the simpler thing is to potentially biopsy the fibroadenoma, particularly in the setting of it being a lump. And then the second question is, once you've confirmed what the pathology and you've got a benign lesion, how do we manage it moving forward? Majority of fibroadenomas tend to settle with time, but they have a varying course. Some will grow. So there's about a 30% chance of, slightly less than that, of something getting bigger. And for that reason, I tend to, if there's a biopsy, I think it's, both the imaging and the biopsy correlate, it's reasonable to consider a 6-month review. In the setting of pregnancy, we probably reduce that follow-up just to see what's happening with it. And then in terms of the rate of growth, if something's growing disproportionately during that time, we would consider operating on it. So if you've got a 1 centimetre lump and it's grown significantly over 6 months, we would have, that's when we'd start to consider the pros of getting more tissue And the rationale for an excisional biopsy is you're getting all the tissue per se. Generally, as we've spoken about, the whole 3 centimeter lesion is how accurate is the biopsy that we've done? Does it correlate with the true lesion? And we've not uncommonly had lesions that have had core biopsies, but because of size, the core hasn't always correlated with what the true lesion is. So the cores are great. You have to also consider, what does a lesion look like? And if it looks like it's a well smooth defined lesion, that's great. If it's starting to have other features such as significant lobulations, or the capsule's not great, and there's a core biopsy, it's balancing a number of factors. But as a general rule, once lesions hit 3 centimeters, we'd be offering an excisional biopsy for the patient and working with the patient about their options. And whether it's us or the GP working with them, we're happy as long as the patient's in the setting of a growing lesion or an enlarging lump, has had those appropriate conversations and has a management plan in place.
So I'm going to have to slow down with the questions because there's almost 40. The last 2 cases with breast cancer, the one that was operated on while pregnant, will she can be able to breastfeed? And what do you tell them about subsequent pregnancies and their risk of breast cancer?
Yeah, so in the setting of breast, like after she's had delivered the baby, her ability to breastfeed wouldn't be present while she's on chemotherapy. So we would have to get through a chemotherapy, and then breastfeeding she could potentially express, but we wouldn't be giving it to the baby during chemo. So commonly what happens is, if we can time the chemo to finish close to delivery, and then that's great, because then you've got time for it to leave the system before considering breastfeeding. Relating to the treatment side, where she's had the excision, she won't be breastfeeding so much from that side as she'll be having treatments on that side. But based on the volume you can produce from the one breast, per se, she would be able to breastfeed on that side. And we see breastfeeding not just in the setting of like this patient where you've had where you've currently have a cancer, but even in those patients that have had radiotherapy before on the breast, on the side that's had treatment, it's harder to breastfeed from that side, but commonly they can breastfeed from the other side and accommodate.
And in terms of having breast cancer, what would you counsel them about future pregnancies and their risk? Yeah,
it's not uncommon to have patients that we're seeing so many young patients with breast cancer, that but for patients in their life plans to consider further pregnancies and further in the future. This is the moment in time where they're going through treatments, and it's balancing the type of cancer, how much a hormonal interplay has to do with their cancer. And as a general rule for patients, once if they have tumors that are low, not metastatic, and even with nodal involvement, like and they've had appropriate treatments, we tend to get to that 2-year time frame post-treatment, and then would work with them with the oncologist around their options. And obviously, it's not a dichotomous thing. It depends on your risk, depending on the type of cancer. There are easy ones, which are the low grade ER positive ones, estrogen receptor positive ones, where their risk is very low of recurrence, and then you're balancing it versus a higher grade hormone positive one driven by estrogen, where you'd be considering whether or not they'd be appropriate for further pregnancies. But the way we tend to do it, commonly that group would have their ovaries suppressed for a period of time with Zoladex and be on an aromatase inhibitor, but working with the oncologist after they've completed chemo and they've been on that treatments for a number of years, it would be a break coming off it. They'd start menstruating again and then consider their fertility options. The other bit, which is harder for this that second last patient that we have discussed, we obviously don't have fertility options for her. She's already 37, but she's currently pregnant. So it's not like we could, do IVF for her, but for a lot of our younger patients that have breast cancer, we would consider that. And so they're aware of their options early in the piece, and it's not forgotten of during their treatments.
So I think that ends our question time. I'm sorry if we couldn't answer all the questions, but that was a fantastic presentation and great cases that we learnt a lot. Thank you, Dr. Warrior.
Thanks, Effie, and thanks everyone for joining on a Saturday. If you've got any questions, feel free to reach out. I'm happy to write some answers as well after, if Effie and the team, Lauren, can get them through. I'm hoping it's been worthwhile for you on your Saturday.
All right. So thank you very much, Lauren, for inviting me, and thank you all for joining on a Saturday. And a special thank you to Dr. Dietz, who has kindly agreed to swap the time with me, because I'm in the operating theater like most of you can see. And I was not going to be able to make it at the time that was allocated to me. So without wasting time, I'll just get on with it. So like most of you know, failure to conceive after 12 months of regular unprotected intercourse is what we define as infertility. But I would like to actually get rid of this term infertility, because there are very few absolute cases of infertility that we now see. For most people who approach us, we are able to do something. So I would rather use the term subfertility, which is less stigmatizing and less absolute. Of course, in women who are over the age of 35, we do recommend that we start investigating after 6 months of trying, only because age has a huge impact on fertility, like we'll see in the slides that are coming up. Fecundability, although, is a little bit different. It's the probability of achieving a pregnancy in one menstrual cycle. And like anything else, the first few attempts have a higher chance. And in the first 3 months, it's generally about 25%. But after that, it's about 15% per month for the next 9 months or so. And in general, we just quote 15% per month to all our couples. Subfertility, unfortunately, is quite prevalent in the community. About 1 in 6 couples will approach us with fertility issues, of which female factors will constitute about a third. Male factors will constitute about 8 to 10% cases of just pure male factor. But sometimes there are problems at both ends, and a third of the couples will actually have problems with the male and the female partner. And in spite of our best efforts, 5% of people will remain what we call as unexplained subfertility, where we haven't been able to find an obvious cause. Of course, 15% do conceive at the time of investigations, because some couples do get a bit anxious within 3 or 4 months of trying and come running to us. And if we start investigating them, then by the law of nature, while we are investigating, they find themselves pregnant. Now, I've just put in a list of the causes of patients that approach us for fertility issues, of which ovulatory dysfunction seems to be the most common one. About 1 in 4 to 1 in 5 couples who approach us have some issues with ovulation, of which polycystic ovarian syndrome, like most of you know, is the most common cause. Age, again, we're going to discuss a little bit more in detail, so I'll leave it here. There can be tubal damage, which can block fallopian tubes in the form of pelvic inflammatory disease or a lot of scarring from endometriosis. In the developing world, tuberculosis is still quite rampant. Some people may have had extensive pelvic surgery leading to adhesions and tubal blockage. So assessing fallopian tubes is reasonably important when there is a history that suggests that there could be a tubal block. Sometimes it can be only a mechanical tubal block at the proximal end, where maybe some menstrual debris or some mucus has just floated around and gone into the proximal tube and blocked it. Endometriosis is a huge cause of subfertility, and not an uncommon problem. We see it in about 20 to 25% of women who approach us for fertility issues. It can cause a lot of anatomical dysfunction in the pelvis by causing a lot of scarring, and also some functional impact in the form of having its impact on egg quality, embryo quality, the actual endometrial lining. So there are various levels at which endometriosis can affect fertility. Sometimes people have only coital issues and can't have penetrative intercourse because of either vaginismus or sexual dysfunction, like erectile dysfunction on the part of the male partner. Often we'll find cervical factors where there has been stenosis of the cervix where the sperm can't get through, or there's a lack of normal cervical mucus, especially in women who have had extensive cervical surgery like a cone biopsy. In men, the problem could be at the pre-testicular, testicular, or post-testicular level. And in spite of our best efforts, like I said, and after looking for all this, there will be at least 5 to 7% cases where I will have to label it as unexplained. So let's look at what the role of the general practitioner is. The main thing that you as colleagues can do is to try and diagnose simple subfertility issues and start treating those issues if possible. But I would expect that a lot of couples would approach you for some education and some basic evaluation. And we'll talk a little bit about basic evaluation, including genetic screening, that is now becoming quite popular. It's very, very important to optimize their periconceptional health, because we know that the periconception period is going to actually determine the fate of that pregnancy and ultimately the fate of that baby that's going to be born. It's a very stressful time for couples, like we can imagine, because they've been trying for a pregnancy and they're not getting there. And the need for emotional and psychological support cannot be understated. And the optimal time to refer to a fertility specialist is also important. And certainly after 12 months of trial, it may be prudent to refer these couples to a fertility specialist. So like anything else we do in medicine, history, examination, investigations, and advice is the order in which we are going to look at things. So if we start looking at the preconception history, history of smoking and alcohol, both are quite important, but smoking is an absolute factor that I would recommend couples not to get involved in, because it does reduce the success of any fertility treatment by at least about 40 to 50%. So even women going through IVF will probably need double the number of IVF cycles compared to women who don't smoke and are of the same age. Alcohol in social levels is fine, but excessive alcohol, like we all know, is not a good idea for a pregnancy. We look for other drugs like methadone, heroin, cocaine. All these can cause suppression of the hypothalamus and ultimately affect fertility. Medications are important because we want women to be on medications that are safe in pregnancy and are not contraindicated. And if they're on antihypertensives or other medications, then it would be prudent to change over before the pregnancy. And of course, family history is important, because if there are genetic issues in the family, then they could be carriers of those genetic issues and then ultimately pass it on to the offspring. So what about the differences between men and women in terms of history and examination? For both of them, BMI is important. And again, the statistics are pretty similar to smoking, where BMI does reduce the success rate by about 40% over a BMI of 35. Blood pressure, breast examination, and pelvic examination are definitely a part of routine evaluation for all women. And the Andrology Society does recommend that men should have at least one testicular examination in adulthood. And the reason is that sometimes we can start suspecting problems, especially in men who have azoospermia, just by doing a testicular examination. So if we look at an example of Klinefelter syndrome, 1 in 650 men have this problem, and that means it's not a very uncommon problem. The testis is extremely small and firm in men with Klinefelters. And for those people who do not have an experience of judging the testicular volume, we can use what is called as an orchidometer that has been shown here, where you compare the size of the testis to the size of the bead that it corresponds to. And over a period of time with experience, then you don't need to use an orchidometer. Up to about 75% of these men are actually never diagnosed unless they present for any fertility issues. In terms of preconception investigations, I'm sure this list is something that you're all very familiar with, because this is like a routine prenatal or an antenatal screen that we would be doing. So pap smear, of course, we need to make sure that they're up to date. And the whole serology is important because we need to make sure that their vaccinations are complete. Plus, we know that TSH and vitamin D play a very important role in pregnancy. And even subclinical hypothyroidism has impact on a pregnancy. And if there is a family history of genetic issues, or if they belong to an ethnic background that has genetic issues that are quite common, then we should offer genetic screening for those particular problems. For men, again, serology is important because infections can be passed on to their partner and ultimately to the baby, and may consider chlamydia and gonorrhea testing if they have higher risk behavior or if the female partner has screened positive. In terms of preconception advice, we need to make sure that their immunizations are complete, and I would be heavily dependent on all my GP colleagues to make sure that this has been done either during or before the time that they have been referred, because obviously they have more access to you, and it is very routine for women to present to you for vaccinations. Certain women will need pneumococcal vaccines or other vaccines when their spleen is not functional, as in if they have had a splenectomy or they have asplenia or impaired immunity for some reason. And like I said earlier, we need to guide them through their BMI, smoking, alcohol, and prenatal vitamins, as we have already checked. In terms of men, again, tell them not to smoke if possible, control their BMI, and make sure that their whooping cough immunity is current, because most units now in Sydney will insist on a current immunity for whooping cough, especially if the baby has to go to the special care nursery and be there for a few days for the father to visit. For the couple, of course, we need to go through what fecundity means, how they can predict their ovulation, what is the fertile time in the menstrual cycle, make sure that they have a good frequency of sexual intercourse, and get rid of other myths that are often prevalent in the community in terms of fertility. Now, I've been saying that we'll look at age a little bit later. So here we are. In terms of age, we all know that as the female age advances, fertility reduces and the issues with pregnancy starts increasing. And the main reason for that is the decline in the oocyte quality and quantity. As women, we are all born with all the eggs that we are ever going to have. And as age advances, the risk of aneuploidy increases, which then subsequently increases the risk of a miscarriage. So age seems to be the most important factor having an impact on fertility. What about the duration of infertility? So if they've just started trying, then their fecundability is as high as 20%. But if they have been trying for a period of 3 years or so, then we can see progressively with time, their fecundability decreases to about 1%. And certainly at that stage, we would say it's prudent to get some assistance. In terms of predicting ovulation, I'm sure most of you are familiar with this graph, which shows that just prior to ovulation, the main hormone that we're looking for is the LH hormone, which surges. And it is this LH surge, which is the main principle that is used in terms of predicting ovulation. So if we have a look at the fertile time during the menstrual cycle, and if we say that day 0 is the day of ovulation, then the day 0 minus 2, those 3 days are supposed to be the most fertile period in the menstrual cycle. And this has been studied also in different age groups. And again, like we can see here, day 0 minus 2 are the days which are most fertile for the woman in that cycle. So what we are trying to catch is the 2 to 3 days before ovulation, which is why the LH surge is very important, because the LH does start rising about 36 hours prior to ovulation. There are various ways of predicting ovulation, and the best, of course, would be to do a series of blood tests, but that does become a little bit invasive. In the past, people were asked to maintain basal body temperatures, but we have to remember that temperature rises after ovulation. And I've just said in the previous slide that the 2 days before ovulation are important. So I don't think that temperature charting gives any predictive value in terms of ovulation, and certainly something that I stopped doing a long time back. There are other methods like ultrasound, or looking for a cervical mucus fern pattern under a simple microscope. And that may give a good indication that the woman is about to ovulate. And there are now kits available in the market that women can use in the comfort of their own home, just by doing a urine test or a salivary test to predict their ovulation. In terms of assessing the couple after going through all this at basic advice, when should we start assessing? What are the investigations that we should do? So in terms of infertility assessment, a routine preconception screen, like we have said earlier, is important. And then starting to look for any obvious problems. So is this woman ovulating? Does she have a regular menstrual cycle, which is what will tell me that yes, she is regularly ovulating? Is there any risk of previous tubal damage in terms of STIs or PID? Does she have symptoms that may suggest endometriosis like dysmenorrhea, dyspareunia, or premenstrual spotting? For men, go through history of undescended testes, any inflammation to the testis, any trauma or torsion which required any surgery, and for both of them, make sure that the frequency and timing of sexual intercourse is appropriate for the fertile period. Virtually, we recommend all women and couples to get investigated after 12 months of trial, because 85% will actually conceive in the first 12 months. And out of the remaining 15%, we would expect that at least half of those would be pregnant in the second year of trial. Thereafter, the pregnancy rates are extremely low, coming down to less than 10% per year. So an earlier investigation may be indicated if you think that there is likely to be a problem, like a woman is getting only, say, a couple of menstrual cycles a year and there's obvious issues with ovulation, then there's not much point in telling her to try for 12 months and then come back. Or if the couple are getting very anxious, either because of the female partner's age or any other obvious issues that they may have. So in terms of the investigations for the male, of course, it is the semen analysis, which is the standard investigation that we are going to perform to look for the volume, concentration, and motility of the sperm and morphology. And we also recommend anti-sperm antibody screening, which affects fertilization. If possible, refer to a dedicated andrology laboratory, which will give a much better quality result and more sensitivity to the result, and advise them to minimize the time to analysis of the sample. If they're collecting the sample at home and bringing it to the lab, then they should get there within an hour of collection. And we do recommend a repeat sample if it is abnormal. If it is normal, then we can take it on face value. For the woman, in the early follicular phase, we can do a hormonal profile, including an FSH and an estradiol, which gives us some idea of their egg reserve. And we could also do what is called as a mid-luteal progesterone, which often will be day 21 in a lot of women who have a regular 28-day cycle. And that is only if we are worried that they may not be ovulating. If, of course, they have irregular cycles and if ovulation does seem to be an issue, or if they have signs like galactorrhea, then we can run a full screen of androgen profile and prolactin on them to know if those are the causes for ovulatory dysfunction. Prolactin levels should always be done as a fasting sample in a non-stressed state and in the follicular phase of the cycle. And this is assuming that TSH has already been included in the preconception screen. In terms of a pelvic ultrasound, again, it's good to do it in the follicular phase when the lining has been shed out completely so that small polyps and small fibroids in the endometrium may not be missed. Transvaginal ultrasounds will give much better information, and consider a hycosy if tubal damage is suspected to look for tubal patency. What about other investigations like anti-Mullerian hormone and karyotype? I'm going to go a little bit into detail because these are important as far as pre-test counseling is concerned. So AMH, like we all know, is produced by the small follicles that are present in the ovary. And of course, in that sense, they reflect ovarian reserve. Consistently, this has been the best predictor of ovarian reserve and a good predictor of response to IVF in terms of the number of eggs that I can expect in a cycle. They're very helpful markers in determining the dose for IVF, for the controlled ovarian stimulation that we have to do. And also if somebody is going to go through chemotherapy, which is going to damage their follicles, then susceptibility to chemotherapy may be judged using AMH. This is a nomogram that came out of my own research a few years back, where we now use this to put their AMH value on this graph and try and judge where they fall in terms of their own age group. And hopefully most women would fall near this bold green line, which is the median level. In terms of the test, it can be performed anytime during the menstrual cycle, and it can also be performed if women are on a short-term course of oral contraceptive pills. But the important thing to remember is do it only if it is going to change behavior or management. And we need to carefully counsel women before we do this test, because it does cause a lot of anxiety for women who have a low AMH value, especially if they have not started trying for a pregnancy. So if we find a low AMH value, then it means that earlier menopause may be likely, and there is a likelihood of poor response to IVF as well. But they are not necessarily less fertile. And that is the important message to give. So if they've been trying only for a couple of months, I wouldn't necessarily say that they need fertility treatment just because their AMH is low. Sorry. AMH can be low in some pathological conditions like genetic mutations with fragile eggs, or even in patients who have endometriosis. And very high AMH levels are found in women with polycystic ovaries. So a low AMH almost excludes polycystic ovarian syndrome. With high AMH, like I said, it is very, very common with polycystic ovarian syndrome. And these women are at a risk of ovarian hyperstimulation. So I need to be very careful with their IVF cycles. A high AMH in a woman at an advanced stage may make IVF more successful just because we'll get a larger number of eggs and then a better selection out of those eggs. What about karyotype? Should it be offered to all infertile couples? Sorry. So the answer to this question from my point of view is yes, because for subfertility does have a higher chance of finding a karyotypic abnormality in one of the partners. It's about 4 times higher than the general population. But it is an expensive test, and I agree that we can be selective. And this is the selective group of patients that we might do it when there is severe male factor subfertility, recurrent miscarriages, recurrent IVF failures, a woman who has gone through premature ovarian failure, or who has a very low egg reserve. In terms of educating couples, we have already discussed all this in the previous slides. I've just summarized it here so that it comes up as one slide for all of you. So we'll talk to them about the supplements, about their chances of conception, how to predict ovulation, frequency and timing of intercourse, optimizing their lifestyle factors, and genetic screening. And there was this fantastic paper that was published just on the effect of lifestyle. And like we can see, all aspects of lifestyle have been studied, and the most important ones are labeled here, where we can see smoking, alcohol, excessive caffeine, illicit drugs, and toxins, all of which will reduce fertility by a significant proportion. Looking at the management, and I know that this was mainly in terms of a GP's evaluation for fertility, but I thought once you evaluate, you might be interested in knowing what the fertility specialist is likely to do, because that's a very common question that your patients are likely to ask you. So the management is largely dependent on the cause, but lifestyle modification is an important part of counseling for all couples. If they have ovulatory dysfunction, then you can safely let them know that ovulation induction is something that the fertility specialist might talk about. Drugs like clomiphene and letrozole that you're all very well aware of. And sometimes we even have to use gonadotropins in women who lack FSH and LH from the pituitary. And that's what we then need to supplement for them to ovulate. Of course, we would treat the cause, if possible, of ovulatory dysfunction. If they have polycystic ovarian syndrome and they have not responded to just oral tablets and medications, then we might even think of laparoscopic ovarian drilling. Insulin sensitizers is something that you all are very well versed with, and metformin is the commonest one that we use because these women are at a higher risk of insulin resistance. And ultimately, if nothing works, then assisted reproduction is always an option. If you've done a tubal patency test and if the tubes are blocked, then you can tell your patients that we will discuss surgery with them, because some patients will not like the idea of assisted reproduction, either on religious or other grounds. And certainly tubal surgery is very real and something that we often do. It may be in the form of trying to open up the fallopian tube at the distal end by doing what is called as a salpingostomy, or if the block is at the proximal end, then by doing a hysteroscopic procedure and putting a guide wire through to open up the tube at the proximal end. And sometimes the tube is very badly damaged and it affects outcomes of IVF. And that's when we might even land up removing the tube. But assisted reproduction does remain the mainstay for tubal damage. This is what a hydrosalpinx would look like. And like you can well imagine, this tube is only going to give trouble to this woman. It's not going to give her a healthy pregnancy. Her chance of an ectopic pregnancy is going to be very high. And sometimes it's better that this tube actually comes out through laparoscopic surgery. What about women who have endometriosis? Expected management is an option because not all women with endometriosis will have fertility issues. So you can reassure women who are young and who have been trying only for a short period of time. But if it comes to treatment, then again, it's either surgery or it's assisted reproduction. In terms of surgery, with mild to moderate endometriosis, there can be definite improvement in natural fertility. But the data is quite controversial in terms of severe endometriosis. Pre-IVF, is it necessary to remove endometriosis? Very, very controversial again, unless of course they have a very large ovarian cyst, which is an endometrioma, which then increases their risk of getting a pelvic abscess with IVF, or it blocks the view and blocks the egg aspiration during an IVF cycle. And of course, assisted reproduction, like I said, is always there if the conservative or surgical management options do not work. In terms of male factor, again, treat the cause if possible. So if a man has a varicocele or hypogonadism, that can be very well treated medically or surgically. But by and large, assisted reproduction with IVF and ICSI is the mainstay of treatment. And we can do this not only with ejaculatory sperm, but with also sperm that we can aspirate either from the epididymis or the testis. And if nothing works, and if testicular biopsy or microdissection does not help us to find sperm, that's when we will say donor sperm insemination. So of course, this is all taken very seriously. And we do a full microdissection before giving up on a man's sperm for him to have a genetic child of his own. Sometimes there may be uterine factors that may come in the way of fertility, like fibroids or polyps. And certainly fibroids and polyps that come into the uterine cavity need to be treated via hysteroscopic surgery prior to embarking on fertility treatment. Sometimes there may be intrauterine adhesions or malformations in the cavity which may need treatment prior to fertility treatment. And the most common malformation that we would like treatment for would be a uterine septum, which would increase the risk of a miscarriage to almost about 60%. If it's unexplained subfertility, then of course it's a balance between the cost, efficacy, safety of treatment and the resources that are available. And it's almost always an individualized treatment, starting from very low resource and then progressively moving on to high resource treatment. Just a little bit about IVF, because this is again a question that most people will ask you as to what's going to happen in IVF. What do you think the doctor is going to do? So what we're going to do is evaluate them and then start with what is called as controlled ovarian stimulation, wherein we are giving them some gonadotropin injections to stimulate multiple eggs to mature in that cycle. Because naturally a woman will mature only one egg per cycle, and one egg is certainly not enough for IVF. Once those follicles have grown, we will do a very straightforward procedure to aspirate those eggs out, and then there'll be fertilization of the egg and the sperm in the laboratory. And the embryos that have been created will be allowed to grow for the next 4 to 5 days in the laboratory, ultimately then leading to one of those embryos going into the woman's uterus. And if there are surplus embryos which are likely to give a pregnancy in future, then those will be frozen and kept for future use. So this is how a follicle would look around the time of ovulation in a natural cycle, where we would see only one large follicle. But this is how a stimulated ovary would look with IVF, where we can see multiple large follicles, and hopefully most of the large ones will have a mature egg. This is how an egg collection procedure is done. So a little ultrasound has to go in the vagina, and a little needle has to go through that ultrasound into the ovary to aspirate those follicles. It can be done with a light sedation and a local anesthetic. But of course, if women prefer to go under a heavy sedation, then that is certainly an option. With the insemination, we can do standard insemination with IVF, where we just put a calculated number of sperm around each egg and hope for one of them to get in naturally. But if the sperm count is very low, or if they are not very good swimmers, then we might take one sperm in an injection needle and inject it directly into the oocyte. And this is how embryos are going to grow in the laboratory from the first day, where they have only 2 pronuclei, and then progressively the number of cells dividing and increasing up to day 5, where we have an embryo which has 2 different groups of cells. So this inside group which makes the baby, and this whole outside group of trophectoderm cells which will ultimately make the placenta. And the embryo transfer is a very straightforward procedure with a fine little catheter that deposits the embryo into the cavity. Just one word about pre-implantation genetic diagnosis. So we do have technology now to test embryos in the laboratory if we are looking for any genetic issues in those embryos or any chromosomal abnormalities, especially if people have a genetic history in the family or they are carriers of genetic problems. Like you can imagine, it requires very sophisticated technology, but we can check for most genetic disorders that have been diagnosed. And a lot of counseling goes into this for the ethical, legal, and the social considerations. I'm not sure if most of you have caught up with this. This was something that was introduced by the government to make it very, very transparent as to how different IVF units are performing in this country. And patients can access the Your IVF Success website and put in their parameters to see what their own success rate might be when they go to different IVF units. And when this was introduced, we were obviously a bit worried because we know that we use the best technology in the world. So we had to come out on top. And I'm very pleased to say that for the 4 main parameters that were checked, Janaya did come up on top compared to the other clinics around Australia and New Zealand. So this one shows up about the births per egg retrieval. This one is again births per complete egg retrieval, including transfer of any surplus embryos that have been frozen. And this one is looking only at women having their first cycle. So from their first cycle also, women have a much higher chance with a better technology. This is per individual attempt of embryo transfer, whether it's a fresh or a frozen embryo transfer. And the last outcome is the births per embryo that is transferred. So what is the chance that when I put that embryo in, that will ultimately result in a pregnancy? And like you can see, for all the outcomes, we have divided it into different age groups. And this is the age group that we would be most worried about with very low success rates. But 1 in 4 to 5 women coming to Janaya at this age are also getting reasonable success rates. And this data is quite transparent because we have to report every single cycle, even if it's a cancelled cycle, to an independent database. And this data has been calculated by that independent database. So we have no say in what they're doing in terms of their calculations. And certainly I would encourage all of you and your patients to go on this website and have a look at the different factors that would affect their success rates. So with this, I would like to end my presentation. I hope I've been able to give you some insight into what you can do as a general practitioner, and sometimes a lot more than I can do as a fertility specialist, because your patients are going to be very, very dependent on you, as they have a very good rapport with you, and they are going to come up with certain questions for you. So at this stage, I'd be happy to take any questions if there are any, or if people want to email me later, then my email is on this slide and you can email questions later. Thank you very much.
Thank you, Dr. Karia. That was very informative. A few questions have come up. If you discover subclinical hypothyroidism as a GP, would we treat it or would we refer on?
So in terms of subclinical hypothyroidism, I'm sure most of the recent data is quite controversial, but we do know that it does have some impact on the mental development of the fetus. So there has been a recent change in the Endocrine Society guidelines. We were using a cutoff of 2.5 for the TSH. And this is assuming that obviously the free T4 and free T3 are normal, because we're talking of subclinical cases. And there was a recommendation made that if these women have a TSH of more than 2.5, then we should start treating. But recently it has been updated, and now a TSH of 4 is being used as the cutoff for subclinical hypothyroidism. Of course, I would also look at the history that this woman has. So if she has had recurrent miscarriages, recurrent IVF failures or implantation failures in the past, and if she has very high levels of antithyroid antibodies, then I would be more tempted to treat her. But if her TSH is between 2.5 and 4, and if she doesn't have any of the other factors, then I think it would be reasonable to repeat the thyroid function in 8 to 12 weeks and keep an eye on it. And certainly if the TSH keeps worsening, then consider treatment. As far as treating yourself versus referring on is concerned, again, it will depend on the severity. And if it is a very mild subclinical hypothyroidism that you need to treat, then I think it would be reasonably safe to start somewhere between 25 and 50 micrograms of levothyroxine, with the understanding that, yes, we do need to keep an eye on the thyroid function regularly.
Thank you. There were some questions about AMH. If you get a high level, would you still stimulate for a cycle? And does the level go up after endometriosis is treated?
So the AMH obviously are the most common questions that we get when we do any presentation, because it is a very controversial thing. So if somebody has a very high AMH, yes, if they need an IVF cycle, we would still need to stimulate them, because AMH is reflecting the small follicles that are present in the ovary. And we do not aspirate any of those small follicles, because they would not give us a mature egg. So if they need to go through IVF, we need to stimulate them. But what I was trying to say in my presentation is I have to keep my hands very tightly controlled, because these are the women who are going to have a likelihood of over response and get overstimulated and then land into the hospital with symptoms. So the monitoring needs to be very vigorous, and the dosage also needs to be calculated very appropriately. Now, one thing that is important is women with severe polycystic ovarian syndrome do tend to have a very narrow therapeutic window for the dose of medications that we use for their IVF cycles. And sometimes it takes a long time for us to actually judge that therapeutic window before we can actually start stimulating them. In terms of the second question of endometriosis, yes, that there is some data that we may see a slight improvement in AMH levels after endometriosis surgery, but certainly not a significant improvement, because AMH is just a reflection of the egg reserve. And endometriosis surgery is not going to change the woman's egg reserve. If we start talking in terms of recovery from chemotherapy, then yes, there is some evidence that if you check AMH levels distant from the time of completion of chemotherapy, then you may see some recovery in the ovary.
Thank you. There were questions about vaccination. Is COVID going to be added to the list? And yes, the DTPA, is that for male and female that you recommend?
So in terms of COVID vaccination, the Reproductive Endocrinology and Infertility Society of Australia and New Zealand have actually come up with a statement which we share with all our fertility patients. And currently there is absolutely no recommendation that women who are planning a pregnancy, planning fertility treatment, or women who are currently pregnant need to avoid the vaccine, because we know that this is not a live virus vaccine. And the only vaccines that we need to avoid in pregnancy are live virus vaccines. This is an mRNA-based vaccine, and we certainly think that whatever we know about the COVID vaccine today allows us to promote it for women who are planning a pregnancy or who are already pregnant. In terms of other vaccinations, yes, we promote it for both the male and the female's partner. Especially what I was referring to was the pertussis immunity, because we did have in 2015 a fair few cases of whooping cough in newborns, and that is why the government actually came up with this whole program of trying to immunize all pregnant women. And even if they have had a shot in the last 5 years, we are trying to immunize them in the current pregnancy and create some passive immunity that crosses the placenta and gets into the baby. So all women who are pregnant around the 28-week mark are recommended to have a whooping cough vaccine. Family members who are going to visit the baby are also recommended to have the vaccine and keep their pertussis immunity current.
Now, another question that GPs get asked is the value of the ovulation kits. What are your thoughts?
I think they're actually reasonably sensitive, and most of them do give a good indication of the fertile period. I don't think that we should take trade names here, but there are some common ones I'm sure that you know that there are in the market. So if women are using it properly, then yes, I think they give a reasonable indication. Nothing can compare, of course, to blood tests. And if we do hormonal evaluation on bloods, then of course we'll get a better accurate indication. But blood tests are a little bit more invasive. And women have to obviously go to the laboratory, whereas the kits is something that they can use at home. So most women who have a regular cycle and are just trying to judge their fertile days will be okay with using the kits at home. For the ones who have very irregular cycles, they're probably going to need ovulation induction, and then we are going to monitor their ovulation through the fertility unit.
Thank you. There was a question about ovarian function and the mechanism that metformin, how does it work, and how does the ovarian drilling improve the function?
So that's a fantastic question. And like we know that metformin is largely used in women who have insulin resistance. And these are women who have a tendency to polycystic ovarian syndrome. Now we know that the two main issues, hormonal issues with polycystic ovarian syndrome, are the hyperinsulinemic state and the hyperandrogenic state that these women have. And it is the high androgens that actually create a very high androgenic environment, which then doesn't allow the follicle to grow nicely and for the woman to ovulate. And certainly insulin does play a role in worsening that hyperandrogenic state. It works through the IGF receptors and then worsens that state. So if we reduce their insulin resistance and make their body tissues more sensitive to the action of insulin, then that is going to improve their chances of ovulation. And there is some data also that these women, when they go through ovulation induction, may respond better in terms of their response for clinical pregnancy rates, ovulation rates, and live birth rates. The important thing to emphasize is that metformin is often given to all women who are labeled with polycystic ovarian syndrome. And I think it's important to judge the ones that have insulin resistance and only use it for them and not use it for all women with insulin resistance.
There was some questions about, is it worth GPs doing HICO-C scans, prior to referral?
So no, I don't recommend tubal patency testing for all women, especially if they have tried for a very short period of time, or if they're going to have only simple fertility treatment like expectant management or ovulation induction, unless there has been a history that is suggestive from the past. So if they've had pelvic inflammatory disease, sexually transmitted infections, if they've had major surgery in the pelvis, or if they have had surgery that could lead to secondary infections like a bad bout of appendicitis, very purulent appendix, gangrenous appendix, all those would make me feel that yes, the tubes could have been affected. In the developing world, if somebody has a history of tuberculosis, and especially if they have a history of abdominal or pelvic tuberculosis, then certainly quite important to check the fallopian tubes. So I would leave it to the fertility specialist or the gynecologist to decide that, only because one is they might not need the test, and second is after their evaluation, for some reason, if they need to have a laparoscopy, then their fallopian tubes will get checked at the time of laparoscopy anyways. HICO-C is a pretty painful test. And if they need to have a laparoscopy later, then I wouldn't put them through that painful test. The other problem is it's quite an expensive test as well. It could cost about $400 to $500. So it would be best to leave it to the fertility specialist after they've done a full evaluation and then decide whether they need that test. In terms of laparoscopic ovarian drilling, it is a procedure that is recommended for women who have failed the first-line treatment for polycystic ovarian syndrome and have not responded to clomiphene or letrozole in terms of ovulation, especially in women who have very high androgen levels. Because we know that in polycystic ovarian syndrome, the ovary is quite big, and it's the central stromal tissue that's making all the high androgens. So with ovarian drilling, what we are doing is we're putting a needle right into the center of the ovary during laparoscopic surgery. And that needle is connected to a diathermy machine where we activate the current, and it burns off some of that central stromal tissue, which will then reduce their androgenic environment, and that will help them to ovulate. So certainly about 60 to 70% chance of ovulation in hyperandrogenic women who have not responded to first-line therapy. And the benefit is, of course, that it reduces the risk of having a multiple pregnancy, because when you do ovulation induction, that is one of the risks that we are taking. In fact, this morning I just canceled a cycle because a woman has got 3 follicles growing on her uterus, on her ultrasound, while monitoring her ovulation induction cycle. And certainly her risk of a multiple pregnancy is then very, very high. So I wouldn't be recommending that for her. And in terms of the success, it's about 60 to 70% chance that she will start ovulating, and then she'll have a single ovulation, which will then improve her chance of having a single healthy pregnancy.
And a final question, a few GPs are asking whether they can prescribe clomiphene. Can you comment?
So of course, GPs are allowed to prescribe clomiphene, but in terms of clomiphene, like I said earlier, the main risk that we are going to take is multiple pregnancy. And multiple pregnancy is a serious risk because it does increase the risk of having abnormalities and problems in the baby by about 6 times. In fact, we now know that the risk of cerebral palsy in twin pregnancies is about 6 times a singleton pregnancy. Of course, it increases tremendously the risk for the mother as well, because there is a higher chance of all the medical complications of pregnancy, a higher chance of requiring operative deliveries. So if they are going to monitor their ovulation induction cycles, and if that monitoring is going to include doing a follicular ultrasound and making a judgment about the follicles, then I think, yes, it may be reasonable. But if they do not have the facility to monitor that cycle, then I think it would be best left to a fertility unit to monitor cycles and reduce that risk of a multiple pregnancy.
Thank you very much, Dr. Karia. That was a fantastic presentation, and we have no more questions.
Thank you so much for having me.
And thanks for having me. I'm joining you from home in the Blue Mountains. Of course, I'm not allowed to join you. And I would, you've probably already had that experience so far. My experience with online meetings generally is that it's a lot harder for everybody, and that there's really the interaction is very limited. So I'd ask you to please, some of what I'm going to tell you, what I'm going to talk about is quite confrontational and, well, controversial. And it is like that on purpose, because I quite like to fire you up a little, and I want a response. I want you to please question me if there's anything that you think sounds off or just not plausible or offensive or politically incorrect. Go for it, please, because otherwise it's just boring. So I'm about to share my screen, and you can see the title is a little different from what you may or may not have on your program. I assure you it's going to cover the aspects of both antenatal and postnatal care that you may be involved in as GPs, as general practitioners. And while my perspective, of course, is the perspective of A, the imaging specialist, B, the urogynecologist, and C, I guess also my perspective is that of somebody who intends to change practice. So I'm an activist, if you want, and this is why this is to a degree an activist talk. If you have anything to criticize about that, then go for it. I very much would encourage you to do so. So let's get started. I'm going to talk about what damage can be done to women in childbirth. And of course, I'm not going to talk about disseminated intravascular coagulation or postpartum hemorrhage or the complications of cesarean section. I'm going to talk about the complications of vaginal delivery, operative or non-operative, to the patient's, to that woman's anatomy, to her pelvic floor and her anal sphincter. Now, it's been known for a while that there's a link between vaginal childbirth on the one hand and later morbidity on the other hand. And nothing much has changed since 2012, last 10 years, when John Delancey, one of our main competitors in Ann Arbor, Michigan, pulled it all together and produced that slide. So down here, that's supposed to be vaginal parity, and that's the relative risk. So you can see, while there is an association between parity and anal incontinence and urinary incontinence in general, it's by far the strongest for prolapse. That's important because a lot of people still think that it's mainly incontinence that is the issue. And that's due to the experience of a large proportion of women who've been pregnant, that during pregnancy, in particular the first pregnancy, a lot of women would, for the first time in their lives, encounter urinary incontinence. But the beef in the sandwich, I'm sorry, that doesn't quite sound right in this context. The public health issue is very much one of prolapse, much less so of incontinence, both due to sheer numbers involved, numbers of procedures required, as you can see here on the right-hand side of the slide, and also in terms of numbers, that is how many, in terms of the effect size, that is the strength of the association between vaginal childbirth on the one hand and prolapse on the other. And there have been a number of long-term studies by now, PROLONG in the UK and in New Zealand, SWEPOP in Sweden, MODE in the US, all showing the same. The reason for that is that there's a clear mismatch between female human anatomy and what is required of it in childbirth. The yellow here is a finite element model of the levator plate of the pelvic floor muscle. And that is essential because it bounds the largest hernial portal, the largest potential hernial portal in the human body. You know, there's a number of potential hernial portals like the inguinal canal, femoral canal, the umbilicus, and in the, the hiatus with diaphragm, of course. But the levator hiatus, which is this space, is by far the largest in somebody who's got no problems whatsoever in a 15 or 20-year-old, okay? And to give you an idea, you know what the potential size of those other hernial portals is. The size of this is, in average, in young nulliparous Caucasian women, 15 to 16 centimeters square. Now, the baby's head doesn't need 15, it needs 68 centimeters square, which means that this space, this potential hernial portal, this gap in your abdominal envelope has to distend enormously. And when I first produced that slide, which is, the data is from Lennox Hoyt in Florida, who's a urogynecologist with whom I've done a bit of work in the past. And when I first put that slide up my first son was about 13 or 14. And of course, he knows way too much about, pregnancy and childbirth and whatnot. He, after all, is the child of a midwife and an obstetrician gynecologist. So he looked over my shoulder and asked what that was. I told him it's a baby coming through, and he said, "Oh, that doesn't look very good." And I said, "Yeah, mate, you're right. It doesn't look very good." He said, "Something's gonna go pop." And I said, "Mate, something's gonna go pop, all right." So, and then I asked him, "Where do you think is it gonna go pop?" Because I thought he's gonna say here, and of course that looks kind of in danger after all. That's, the point is, however, that this is not where the tears happen. This is not the perineum, it's the muscle, which is 1.5 centimeters further up. And the perineum and the fibromuscular tissue that makes up the perineum is, of course, protective of the levator muscle underneath. And I should say, in between is the anal rectum, or rather the anal canal and the anal sphincter. So if anything gets hurt there, it'll be skin, perineum, anal canal, in particular the anal sphincter. It won't be the levator. It's too far back. It's protected. But my son's, then I thought he's brighter than he looks, but now he's at ANU, and I acknowledge that I underestimated his brains, and I shouldn't have, because he said it's going to happen here. This is where the damage is going to happen. And indeed, this is where the vast majority of the trauma actually happens. And the story of that discovery and what it now means makes up a fair part of this talk. It's not just the soft tissue that's a problem in childbirth. Of course, it is often or sometimes the bony structures as well. And you can see that compared to the primates, we're not intelligent design, because I remember we had a minor collaboration with Taronga Zoo, and the primates there, and the primate veterinarians there, and it got sunk by a virus, just in case anybody sees any parallels. And the chief vet told me how Pan or Pongo have their babies. It works like this: she's pregnant, she disappears behind a bush, and 10 minutes later she's back with a little one in her arms. Now compare that to the ordeal that can be human childbirth. And part of it, of course, is the mismatch between the bony pelvis and this enormous head. And despite that enormous head, you're stuck with the baby, with the offspring for 20 plus years, in terms of, getting that individual to stand on his or her own 2 feet. So clearly a lot has happened from an evolutionary point of view, from the primates to us. And I don't need to explain to you, it's the upright posture, so that the pelvis is completely rearranged, and it has to be there's a lot more weight bearing happening there, which means the size of the opening is much smaller, relatively speaking, compared to the primates, and it is at the limits of what is biologically possible. Well, can I actually run this? Okay, this is, I'm sorry, it's quite confronting. Maybe I should have had a trigger warning in front of it. This is a cadaver dissection, a fresh cadaver dissection, a dissection of a fresh cadaver. It's really, really hard to do that these days. And this is the only good one I've ever done in 20 years. I haven't done this kind of thing for about the last 10 years because it's just ugly as hell. But then anatomy is important, and this was important because what you can see there, so a lot of tissue has been removed, of course the perineum and very widely the vulva, and you can see the clitoris here, the pubic rami here and there, there's the urethra underneath there. This is the anterior vaginal wall, the posterior vaginal wall, the anal canal, the anus there. And that's ischiorectal fossa. All that yellow is ischiorectal fossa. You can see a V shape here. And that V shape isn't just the vagina, which has had the vulva removed and the external perineal muscles have been removed. It's the levator muscle. And I'm showing this even so it is so ugly, but I need to show this because I should be able to demonstrate to you that the pelvic floor is not a bowl, it's a funnel, and it heads up very, very steeply. So that that's the levator plate in the back with the insertion here, and there's the pubic ramus. So that's where where the red stuff is. That's just behind there. It's attached to the bone, and I think you can see here how it gets wider, ever wider at the top. Don't worry about the bit of plastic there. That is experimental surgery. And then here on the other side, the same thing. So there's a plate, which is not the vagina, it's the levator, and it heads up quite steeply. That's the puborectalis muscle, and I'm about to palpate it. That is what keeps your insides in, that muscle. It doesn't look very impressive, but it very much is. It's usually the strength of your little finger if you're more asthenic, the strength of your index finger if you're kind of a bit more bulky, and if you're a Schwarzenegger kind of type, it's the size of your thumb. It can be as thick as your thumb. Now that's a little more sanitized here. This is a so-called magic cut. So a 3D volume of the pelvic floor has been processed. So there's the symphysis pubis here in the middle. There's the pubic ramus here and there. And there's that V-shaped loop you just saw. It really is like that in the living human being. And I think you also get the idea, it's not so clear here, but I think you get the idea that there is a narrowest plane or area, which we call the levator hiatus, and higher up it gets wider and wider. And what you can't really see here is that higher up also the muscle gets thinner and thinner. It would be surprising if there was no damage to the structure when a baby passes through, due to the enormous degrees of distension. Depending on the individual, can be between 6 and can be between a factor of 1.5 and 6. And this is the world's first known illustration of it says here levator torn from its origin, even though the artist didn't get it right. He put the tear in the belly of the muscle. It is on its origin. It's from a textbook from 1938. I haven't found anything earlier except for one for a monograph, some text in a monograph that was printed in Vienna. It was at Braumüller in Vienna, where in 1908, where the authors described virtual absence of the pelvic floor muscle on one side in women with prolapse. So down here, this is interesting too, the legend. It says here, due to crushing between the blade of the obstetric forceps and the ramus pubis. Well, it's not really crushing. I mean, it's a tear, okay? And then it says very difficult to repair, which is fascinating because that means that Joe DeLee, who was the top obstetrician or the most prominent obstetrician in the US between the First and the Second World War, that Joe DeLee actually tried, or at least some of his staff tried. The result, you can, again, sorry, trigger warning, this lady has agreed to me sharing this video, and you can see that she's doing a Valsalva maneuver, she's doing a push, and there's an obvious prolapse. That's not so much the point. Please consider this is a hernia, okay? It's a herniation of her bladder, and the uterus is not far behind it. But what I'm showing this for is not to show the prolapse. I'm showing it, I'm trying to illustrate the obvious asymmetry in this lady. So both on Valsalva, on coughing, on pelvic floor contraction, you can see that with the contraction, the anus is pulled towards the healthy side, which is over here. And when you look at the skin lines here, they're obviously asymmetrical. It is because underneath the skin here is a complete right-sided avulsion, which is a disconnecting of the pelvic floor muscle from that side. And this is the world's first proper description of such injury. It was possible because Alec Gillespie, who was a VMO at Hawkesbury Hospital, now retired, realized what he was seeing and got me in on a Saturday afternoon, and we took lots of photos and we tried to stitch this. It didn't work, and there's been we've had a total of 4 or 5 attempts, never worked. So we've pretty much given up on doing this in labor ward. There's a very large defect in this lady. The levator tear is exposed by a very large vaginal tear, and there's some fibrofatty tissue visible here. That's the ischiorectal fossa, and the bits here, that is torn levator that belongs here. Its consistency is like sphincter for those of you who've done obstetrics. It's skeletal muscle. We've tried to stitch it, and then we followed her up at 3 months afterwards, and you can see there's an obvious right-sided defect here. So that muscle is supposed to be attached here. Same on MR, also the ultrasound is clearer. So there's the muscle. It should be attached here as it is on the other side, and it is not. The diagnosis is rarely possible in labor ward because most of those injuries are actually behind intact skin. And even if there's a large vaginal tear, really it's a courageous and adventurous obstetrician who starts digging around, trying to work out how deep the damage really goes. Just about everybody just stitches the vagina closed without any consideration of deeper damage. What we do is we place a transducer, usually a 4D ultrasound, a curved array, which first came to New South Wales at least, to the RPA medical center, not far from where you are. In, I think it was October or November 2002, and that's when I was lucky enough to be able to examine patients who clearly had major trauma, and that was possible because of Tom Bogert and his team at the medical center. And due to the support of colleagues, I worked at the RPA at the time, first as a fellow and then as a staff specialist. When we place a transducer on the perineum, for those of you who've done ultrasound, the midline, just a sec, the midline looks like that. So that dark stripe there, it's not staying, no, it's not going to stay. Bring it back a little. The dark stripe is the urethra, and I really ought to show this properly. So the symphysis pubis is here. The dark stripe is the urethra, the bladder neck, the bladder, the vagina, the anal rectum, the anal canal, the external sphincter, the internal sphincter, the external sphincter, the internal sphincter, and around everything loops the levator, the puborectalis, or the entire levator plate really. And we can see it on 2D. So if you go lateral, there's a lot of hyperechogenic stringy stuff here. That's the puborectalis, and higher up, that's iliococcygeus. And now we can run this to show that there's obviously stringy hyperechogenic structure there, which is muscle. And at some stage, I think we'll get the patient to contract. There you see, so it's obviously contractile. Makes everything move, of course. And then we move over to the other side because that's the critical one in this case. And you can see there's a marked difference there. So this is partial trauma. There's a bit that's attached at the front. It's partial trauma only because there's a connection all the way from the anal rectum to the sidewall, which is here. But there's this huge big gap, which is substantial partial levator trauma. That can be palpated. You can feel that you fall into like a hole, and with your finger. Lateral on the sidewall, but 2 centimeters lateral to the urethra. And it's always much lower than you think. So if you ever try this in your practice, you're bound to go too high. Remember that muscle is attached to the inferior pubic ramus. Often that area is then filled with big vessels. I don't know why that is, but it's a common observation. With 4D ultrasound, we don't just get the mid-sagittal plane like you just saw it, like it is here. So the symphysis pubis, the urethra from the external meatus to the internal meatus, the folded up bladder, the vagina, the rectal ampulla, the anal canal, and the levator plate is here behind the anal-rectal angle. We also get orthogonal planes. That means planes that are at right angles to this. So there's the coronal plane with the muscle here and there, and you get an idea of this this funnel shape here, and the fact that it's getting thinner the higher you go. This is the axial plane, and we often use a rendered volume in the axial plane, which incidentally was invented, that was developed to show you baby faces, because this rendered volume, this region of interest, this box here, if you make that fit over a baby face, it gives you those wonderful 3D images, and you can even do that live, which is great fun. In 2005, we published the world's first paper on before or after imaging that is proving that avulsion, that levator tears actually exist. And that was done at the RPA Medical Center, and Valeria Lanzarone helped with that, who is now here out at Nepean as a COGU, as an imaging subspecialist. That's a normal muscle, that's the muscle torn, and this is our palpation model, which we use to which we've been using for the last 5 years to teach people how to pick up that damage on digital examination, on internal examination. The standardization these days is with standardized diagnosis. Now this is internationally standardized, accepted or approved by 6 different societies, and has been published both in the Journal of Ultrasound in Medicine and in the International Urogynecology Journal. Is being taught in an online course which has had over 100 students. So this is actually now pretty watertight, at least from my point of view. So this is how it's done. We slice the entire region of interest, that is the area of the puba rectalis and the lower iliococcygeus at 2.5 millimeter interslice interval. That's obviously a normal muscle. You can see that V shape here. This is better than, you do that on a pelvic floor contraction and you do it live. This is much better than MR. And one of the big advantages over MR is not just that we can do this with a pelvic floor contraction, which makes the muscle more visible, obviously, but we can also, with MR, if you do multi-slice imaging like that, you have to do that on a predetermined plane. So you determine the plane and then you shoot bang, bang, bang. And with ultrasound, at a very high temporal resolution of up to 5 hertz or so, we can record an entire maneuver, and we don't get slices, we get blocks of data, which means we can slice it any way we want. We are not stuck with predetermined planes. That's important because when people do a pelvic floor contraction, the plane of their pelvic floor lifts, changes, and in some people quite dramatically. That's what it looks like in somebody who is abnormal. So there's a left-sided complete avulsion here. You see the disruption is pretty obvious. And here in the upper reaches, there's also damage to the right-sided. So this is the patient's right. That's the patient's left. There's an obvious left-sided avulsion all through here. But there's also damage higher up on the right, which is evident in a complete absence of muscle here. And there's a chunk missing. I think you can probably see that. There's a chunk missing, which is that partial trauma on the right. This lady has a complete left-sided, partial right-sided avulsion. The worst case scenario looks like that when the muscle is completely disconnected on both sides. And something like that is basically guaranteed a prolapse, and often quite soon. I'm showing this very old clip. This clip is 16 years old or so, and I'm still showing it because it gave me a eureka moment, and maybe it does the same for you. That's why I'm showing it. So here's the mid-sagittal plane, and that lady is doing a push. So that's at rest, and now she does a Valsalva. And you can see here the bladder is coming down because it's upside down. So the bladder is moving down, and here's the rectal ampulla moving down. So this lady has at least a 2-compartment prolapse. But what's more important is what happens here. Even at rest, the levator hiatus, the opening of the muscle, looks abnormal. And when I recorded that particular clip, I didn't realize what was wrong. It's too early. It was maybe half a year or so before we realized that in some people, these defects are bilateral. They've happened on both sides. And this is exactly what was the case with her. So when she pushes, you can see that this opening, the largest potential hernial portal in the human body, becomes an actual hernial portal, because that opening, which is supposed to be 15 centimeters square on Valsalva, is now 50. That's enough to push a 32, 34-week baby through without any real effort at all, at least not effort originating from overcoming the resistance of the soft tissues of the birth canal. This is very recent. It's a large systematic review and meta-analysis of the link between pregnancy, labor, and delivery on the one hand, and symptoms of prolapse, objective prolapse, and avulsion on the other hand. And avulsion's in there because it is a very useful proxy outcome measure. It may take 30 years for somebody to notice a prolapse that is the result of something that happened 30 years before. And then it may take another 10 years before she's sufficiently bothered to actually see a doctor. So the mean time between birth of the first baby, which is when it virtually always happens, the mean time between the first baby and presentation for prolapse surgery, it was 34 years in a large study we've done. Of course, there are people who are badly bothered 3 or 4 months after the delivery, or 2 years or 4 years, but in others, it takes a lot longer for the tissues, the organs to come down far enough, so for the hernia to develop, B, for the patient to notice that there is a hernia, and C, for that patient working up the courage to actually see one of us. So you can see here in that relatively busy table that there are a few things that are quite obvious. So the first, vaginal delivery, is by far the strongest risk factor, with multiparity conveying some degree of additional risk for symptoms of prolapse. That is due to confounders. And then there's, of course, cesarean section is very highly protective. And if it says 0.10 there, then that's due to outliers, there's false positive diagnosis or concealed delivery. So really it should be 0. Forceps is the major risk factor here. You can see that that's the case for symptoms of prolapse, signs of prolapse, and avulsion. And you can see the odds ratio is by far the highest for avulsion. The reason for that is that with avulsion, we are closer to the pathophysiology or etiology even. So you know, there's this chain, the pathophysiological chain between some insult and then something develops and ultimately manifests. And because probably by far the most drastic insult that happens there is a levator tear, and because forceps is so strongly associated with it, that's why the odds ratios are so much higher for avulsion compared to objective prolapse, for example. A vacuum is in some studies a risk factor, but in this particular meta-analysis, vacuum did not convey an additional risk compared to normal vaginal delivery, which is crucial. It's an absolutely crucial finding. Avulsion is important because in another meta-analysis we've done a few years ago, we showed that it is the single strongest risk factor for prolapse recurrence with surgery. So it actually matters a lot to urogynecologists. And as an aside, you may be aware there's been this controversy about mesh use. Vaginal mesh so far has been the only intervention that's been shown to compensate for the very substantial effect of avulsion when it comes to making procedures fail. So we just weren't fast enough to tell everybody, including the FDA and the TGA, let alone pressure groups on Facebook. Mind you, they wouldn't listen to me anyway. So in terms of clinical consequences, I need to say avulsion is common. It's between 10 and 25%, depending on the demographics. Also, I should say that in Nepal, we found a prevalence of 2%. The main reason for that is an absence of forceps and birth at much younger age. It's on average 20. At the RPA, the mean age at first delivery is probably 33 or 34 now. In private, it's certainly 34. You know, the more down market you go, the slightly lower, but not by much. I mean, the mean in Australia is probably about 32 years. These are the two main factors, and it was also visible in that previous slide that I showed you. The main consequence from that is that forceps needs to disappear. It has to. There's just no way around that. And it is, and urogynecologists such as myself are getting increasingly noisy regarding that. You'll see much more of that in future. Forceps has actually not, well, you know, when I came to Australia, I thought forceps is disappearing. And in Heidelberg in the late 80s, I was told, in particular, rotational forceps belongs in the museum. So in Europe, forceps was on the way out a lot earlier than in England, which was always more traditional. And of course, the vacuum came from Scandinavia. So Australia has just followed UK trends. And since 2005, in the UK, forceps rates have more than doubled. And the obvious reason for that is the pressure on C-section rates. So if you want to get more babies out the normal way and avoid cesarean, you just try and pull harder. And with a vacuum, you can pull at 80 newtons, even with a Malmström extractor. With a forceps, you can actually, on average, pull at 220 or so. But if you're really strong, you can pull as hard as you want. And I remember people bracing themselves against the delivery chair to get a baby out with forceps. So it's not surprising that more damage is done, because a lot more effort can be put into delivering a baby by forceps. That's why forceps is better at getting babies out. Avulsion is the primary risk factor for prolapse and prolapse recurrence, which means it needs to be diagnosed. It needs to be accounted for in research. And of course, we need to do something about it postnatally. We'll get to that in a minute. First, I need to talk about perineal trauma, and the top end of that is a 4th degree tear, as you know. So 1st degree is just skin. 2nd degree is the perineal body, which means the fibromuscular tissue that sits in a pyramid shape or triangular shape between the skin at the bottom, the vagina anteriorly, and the anal canal posteriorly. And these numbers have been going up and up and up all over the world. It's in the UK, it's kind of obviously the forceps epidemic, but in other places, it may just be better detection. And people have been trying to use 3rd degree tears as a key performance indicator for obstetric services. The problem with that is that the worse the unit is, the poorer they are at actually looking after their patients and diagnosing the damage, the better they're going to look. And the better a unit is at diagnosing this damage and fixing it, the worse they're going to look in the statistics. So obstetric sphincter trauma as diagnosed in labor ward, therefore, is not a useful key performance indicator. It does kind of the opposite. If one wants to use obstetric trauma as a key performance indicator of obstetric services, which is what we should be doing, you need an objective measure. You need imaging. And that would be endoanal ultrasound. Originally, it's been around for close on 30 years, and unfortunately, it's had minimal impact only, even at large tertiary hospitals in New South Wales. I don't know of any place where there's routine follow-up of sphincter tears by endoanal ultrasound, and that is 30 years on. MR is useless, as you can see there. This is a paper from 2019, and that is supposed to show you the anal canal on MR. Frankly, I can't see a thing. And the paper comes to nonsensical conclusions, which is not surprising. What we do is we just simply rotate our transducer by 90 degrees. We tilt it a little, and then we see the external sphincter is a hyperechogenic ring. The internal sphincter is a hypoechogenic ring, and over it is the perineum and the transversus muscle. When we put the transducer on, the main transducer plane is the coronal, which is why we see that ring shape there. So the external sphincter is a bright ring, the internal sphincter is a dark ring, and there's the mucosal star. It is 3D ultrasound or 4D ultrasound, which means we have the orthogonal planes. There's the mid-sagittal here, mid-sagittal, just like what you saw before. And that is an axial plane, which I haven't really made any use of yet. This plane here is really important because it allows us to place coronal plane slices where they need to be. And this makes that method plainly superior to endoanal. And of course, MR is not a competition. So this is obviously the way to go when it comes to imaging the anal sphincter and anal sphincter trauma. In the mid-sagittal, you can see the internal sphincter here. It's a dark stripe. It's basically, that's just the continuation of your bole muscularis, okay? And surrounding it like an elongated donut or torus is this structure here. It's a drop shape here, and it's a drop shape here. It's brighter here than there because I didn't quite get the time gain compensation right. But I think you can see it's a drop shape there and there. And because we can, in the mid-sagittal, we see this fascial plane here between the levator and the anal sphincter, and we can see the internal sphincter ending here. We can place one slice above the external, One slice below the internal, and then everything in between is what we want to see. So this is above the external, looks like a defect. It's not, because we're too high. This is below the internal. There's no internal sphincter there. It's not a defect because we're too low. All the other 6 slices should show both external and internal. That's what it looks like normally. It's really easy for patients, really easy for lay people. There's a dark ring and a bright ring, and the slight irregularities there are just normal. I don't really need to explain anything here, isn't it? There's a break in the bright ring. Okay, so there's that bright ring, and there's a break here, and it's all the way through. It's all the way. You can see it everywhere. And above it is this, it's like a lightning strike, isn't it? There's an irregular, raggedy line, maybe best here, which goes that away, and then that away, and that way, and then towards the sphincter. So this lady's had a spontaneous 3B perineal tear. I'm saying 3B because the internal sphincter really only looks at normal up here, and that's actually quite common because it's really thin up there. So it's a 3B perineal tear, and the way it looks there, in particular here, it's obviously been repaired, and not badly actually. But it's common, as you can see here, we commonly see what's called a residual defect. Now, that's also a 3B perineal tear, but it's much, much worse. In that, the gap is very wide. You can see that the defect angle is measured here. It's enormous. And if it's that symmetrical, it means it wasn't stitched. This is what a non-stitched 3B tear looks like, or one that's been stitched grossly incompetently. It's a really bad appearance. And what makes matters worse is that you can see an episiotomy here. That linear, that's what episiotomies look like. We were the first to describe that. It's a straight line, straight dark line. And maybe some of you have noticed already, it's in an odd location. It should be here. Okay, so it was, or it should go in that direction. So it was started in the wrong place. We call that a contralateral episiotomy. It was cut towards the sphincter rather than away from it. And also, to top it all off, it's really steep. It's an episiotomy should be cut like this, which means that particular accoucheur really stuffed up, and that's not excusable. That needs remedial teaching. And at this point in time, without imaging, you will never know that that's happened without imaging. That's a really worst case scenario. So just to show you a 3C tear. So there's a poorly repaired 3C perineal tear from somebody who needs feedback because that's not right. Okay, it's a bad outcome. So the external sphincter is wide open here. The internal sphincter is also wide open all the way through. This is highly abnormal. It's not nearly the worst I've seen, but it's pretty bad. And we've done a follow-up, a long-term follow-up. One of my PhD students has done a long-term follow-up and showed that if somebody looks like that, the likelihood of her being anally incontinent, even after repair, is way over 50%. That kind of thing, I'd say 70% likely within the first 6 years. And that has, as you probably know, as you may well imagine, it's got enormous implications for that patient's quality of life. And the worst part is that the colorectal surgeons say, well, we're not very good at fixing this. Again, the main risk factor is forceps. This is a clinical diagnosis of sphincter tears. And you can see if you see a forest plot like that, the jury is in. There's really no need to do additional studies. Forceps, mind you, we've known that since the late 80s, that forceps is more dangerous to the sphincter than vacuum. One point I really need to make is that for everything that happens down there, age at first birth is a core factor. And this is from one of my PhD students, Jessica Caldwell-Hall, who published this paper 3 years ago, showing that the older you are when you have your first baby, the less the likelihood of you having what everybody wants, which is an atraumatic normal vaginal delivery. So to push the baby out normally without requiring any help in the form of a cesarean or a vacuum or a forceps, and to do no major damage to yourself. That's what's happened to forceps rates. I really need to look up the 2020 data, but I think the story is quite obvious. This is Nepean here, and there's lately been an increase due to an influx of specialists who've been trained elsewhere and who are not sufficient, have not sufficiently been exposed to what I'm exposing you to now. That's this here is the RPA, and you can see a very substantial increase from the early noughties to now, also maybe coming down a little. The more upmarket you go in Sydney, the Royal Hospital for Women here, where I worked in the between 99 and 03, is here, and the North Shore, of course, comes out at the top. That's not really surprising. It is a function of both older age at first birth, which means more complicated deliveries, and the nature of the obstetric care provided, which depends on where those obstetricians were trained. And if they were trained in England, then I've told you before, the forceps rate in the UK is more than doubled, and the further north you go, the worse it is. Some of the highest forceps rate in the world and the most damage done is now happening in places like Glasgow. That's dreadful. And in Australia, by the way, it's the other way around. The further south you go, the worse things are. And the institutions that take the cake are Monash and Mercy in Melbourne, at least over an average of years. They've been very, very proactive in reintroducing forceps to the obstetric environment in Australia. So for OASI, for obstetric anal sphincter injury, it's the primary modifiable risk factor for anal incontinence in women. And we've just now, for the conference season now, we've shown that it's in the older people get, the less of a role it plays, of course, because other factors come in like irritable bowel and dementia and whatnot. But it is very important in those between the ages of 30 and 50. So beyond menopause, other factors come in. But for younger women, this is a big deal. Forceps is the main modifiable risk factor, and I'm saying it again, it needs to disappear. Exoanal tomographic imaging is the method of choice, as I hope to have shown you. And I've been trying to get this method introduced at hospitals in New South Wales now for about 10 years. We've been doing this at Nepean, now under political threat and pressure. It's being done at Liverpool. Somebody has tried to establish it at St. George's. I'm not sure how far we are. There have been attempts at the RPA. I've offered and offered and offered, but human inertia is well developed amongst my colleagues. They're not superhuman. Finally, I need to say that for those in clinical research, of course, or just for clinical audit, there's enormous opportunity. And I think I've shown you that for something as simple and common as episiotomy, there's lots to do because our practice is not optimal, even in tertiary hospitals in Sydney. So clinical consequences, I need to say that vaginal childbirth is responsible for over 80% of prolapse presentations. That was published in 13 through a Scandinavian study. Avulsion is the primary etiological factor for cystocele and uterine prolapse. Forceps is the primary modifiable risk factor for prolapse, for avulsion. And banning forceps would be expected to reduce the lifetime risk of prolapse surgery by over 30%. This is from a Danish study and a Canadian review. Now, some of you would have heard of that before. Others may be a little baffled that this is not more in the public domain and that we're not talking to, or most patients, the vast majority of patients go through pregnancy and their first childbirth without ever hearing anything of this. And I've had because I come from a legal family, I've always been interested in informed consent. This is a product of Western civilization. It doesn't exist anywhere else on the planet. And as a German, of course, I'd argue that it started with Kant's categorical imperative in 1785. He was a friend of the family of my great-great-great-great-great-grandfather, so I have a soft spot for Kant. The first academic publication was by a guy called Gebhardt in the US in 1957, but what maybe needs to be in there is the Nuremberg Declaration, because after there was a doctor's trial in Nuremberg, you may have heard of that, and of course a guy called Mengele was in absentia, was one of the most prominent there. So the idea was that people must not be forced to undergo medical intervention against their will. And if they do undergo medical intervention, then they've got to be properly informed. That basic principle is under threat right now, as you may well be aware, and we've got to fight to keep it because it's one of the core achievements of Western medicine. In '93, a case made history at the New South Wales, at the High Court, I think, Rogers versus Whittaker, which was written up in the Australian Law Journal. So that was an ophthalmologist who omitted informing his patient of the risk of sympathetic ophthalmopathy. So he did something on the sick eye, and then the healthy eye got bad. The doctor lost because he had not told the patient about sympathetic ophthalmopathy. And you may know better than me what the incidence is. It's a long way below 1 in 1,000. And then the second person, of course, it's Kant at the top there. The second person here is Lady Hale. She was the first female judge on the Supreme Court of the United Kingdom, which goes all the way back to the Star Chamber of Henry VIII, if you have a historical interest. And in the Montgomery versus Lanarkshire judgment, it was made quite clear that if the doctor doesn't warn the patient of an increased risk of something, in the context of medical intervention, then the doctors acts illegally. And there is actually case law in Australia, KSXD versus Calvary and Foot, and I know quite a bit about that because I know the main protagonist. And that was about an obstetrician not warning the patient that she was at an increased risk of stillbirth. So the Montgomery versus Lanarkshire was a shoulder dystocia case. The Calvary Foot case is a stillbirth case. And in early 19, I think, John Pardee, former director of obstetrics here at Nepean, and me, we got 40 minutes of Brad Hazard's time. It was easier then than it is now, I imagine. And we talked to him about he's a barrister, so he understood the term uncovered sovereign risk, legal liability in New South Wales public health, because we argued that on extant law, we're not actually acting legally in antenatal care. So 1.5 years later, we have the New South Wales Consent Manual. Not going to, actually, I need to show you, well, okay, all right, good. Let's go to the Consent Manual a little later. This is the Montgomery versus Lanarkshire judgment, and it says here, Lady Hale, it is impossible to consider a particular procedure in isolation from its alternatives. Where either mother or child is at heightened risk from vaginal delivery, doctors should volunteer the pros and cons of that option compared to a cesarean. And heightened risk from vaginal delivery, what I've just shown you makes it quite clear that anybody over the average age of 32, when she has her first baby, is at a heightened risk. Quite a few other things as well. And I do quite a bit of medical legal work, so I might end up with a text like, or with an opinion, a legal opinion like this. If Miss X had been delivered by C-section without any attempt at forceps, she would not have suffered an anal sphincter tear or a levat avulsion. This is beyond reasonable doubt. If she'd been delivered by C-section, risk of future prolapse would have been reduced by 90%. Vacuum would have reduced the risk of prolapse by half. On the balance of probabilities, she would not now suffer from prolapse. If she'd been delivered by vacuum instead of forceps, probability of a levat tear would have been reduced over 3/4. On the balance of probabilities, she would not have suffered an avulsion. A birth by any other delivery mode than forceps would have reduced the risk of anal incontinence by over 50%. On the balance of probabilities, Ms. X would not now suffer from anal incontinence. And that means the case is lost. So unless, in particular now, since March 20 in New South Wales, unless the risks that I've been talking about are explained to the patient before forceps, and she says, I want a forceps rather than anything else, unless that happens and something goes wrong, the case is medico-legally indefensible. And I think I pointed that out on the basis of, at the RPA, I pointed that out in 16 or 17 on the basis of the results of a prospective multi-center RCT that the RPA participated in. I don't think it's happening. I don't think our colleagues have changed very much. So we've been plugging away at this for a long time. 3 years ago, we had, together with a law academic, Sasha Callahan, we had this piece in ANSC. We need to treat pregnant women as adults. Women should be consented for an attempted normal vaginal birth as for operative delivery, etc., etc. Nobody's doing it. And then the New South Wales Consent Manual came out, and it took me 8 months to know that it was there, because it wasn't even sent to obstetricians. Okay, so we wrote this piece to explain to our colleagues what the implications are, that we urgently need to get our act together, because if something goes wrong at this point in time, the likelihood of that case being indefensible in terms of civil liability is high. And I also need to say that the consent manual, this is the condensation of it, the full text of the consent manual mentions not just civil liability, it talks about criminal liability. That's very bad news for my profession. So the important thing here is that what requires written consent is all planned intervention, like, of course, elective Caesar, of course, but also vaginal birth after cesarean, and we do not do that well. Induction of labor, that's a bit of a bummer because we do a lot of inductions, and then, of course, transient breaches, which is done already. But even for unplanned interventions, for example, instrumental birth, that is a vacuum or a forceps, where time allows, written consent should be recorded. That's quite obvious. And of course, it's supposed to be informed consent, not just, yes, I'm okay. And nobody argues that if there's suddenly bradycardia and you've got to deliver the baby and you can get it by forceps, then you just get it out as fast as possible. But in the vast majority of cases, in my experience, of 100 vaginal operative deliveries, there's 2 or 3 that were that urgent. The other 97 are not. So something's got to change. And the pressure from those who actually see of course, most obstetricians don't see the damage, or at most they see an obstetric sphincter tear, which is massively underdiagnosed. So half of them aren't even picked up, let alone repaired. So the perception of the practicing obstetrician is that maybe 4 or 5% of their patients suffer major trauma. That's nonsense. It's twice as much for the sphincter alone, and then you add another 10 to 15% for the levator. So it's not 4 or 5%, it's over 20. And those who know, or those who are more aware, are, of course, often urogynecologists, that is those who deal with a fallout. It's colorectal surgeons as well, to a degree, and we are going to increase the pressure until finally our colleagues appreciate the need for action. And in this themed issue, which has only just come out, it says here, especially women, either during pregnancy or during planning, or I should say afterwards, so that a risk can be assessed and that they can be informed and empowered to make informed choices. This is very much a legalistic position, and I appreciate that. But I'm sorry, we are, of course, all subject to extant law. So in conclusion, antenatal, postnatal care, this goes for you, for those of you who are involved in antenatal postnatal care, we need to start treating those women like adults. That means fully informed consent at 36 weeks, and it's got to be an obstetrician or a competent ONG resident, people who can actually, who are used to dealing with both the operative deliveries and with the fallout. Postnatal debriefing done by medical staff, and that also to a degree may at times involve a shared care family doctor. And we need to get into diagnosis. We need to establish perineal clinics everywhere that can actually diagnose major trauma, and that should be followed up by early intervention, so that with musculoskeletal trauma, of course, the core issue in sports medicine is early intervention with physiotherapy. So I think we are at the end of this. Please, I've given you a lot of controversy, so I would like to get some back. Thanks very much.
Thank you for a fascinating presentation and upskilling our anatomy. A lot of GPs see postnatal 6-week checks. Is there anything we can do better or assess? And, you know, is there any local ultrasound places able to do that quality ultrasound, or is it very much tertiary?
Well, for at least 5 years, I helped Sydney Ultrasound for Women to provide such a service. So I trained up some sonographers, and then they sent me the discs, and I did the reporting. At that time, it wasn't really postnatal patients. It was mostly gynecological, urogynecological. That stopped when the one sonographer that was really interested went into maternity leave, and so I don't think at the moment, I don't think that facility exists at the RPA. It does exist. We can provide it in Bankstown and Liverpool in private as part of our group practice, and we can certainly provide it in Penrith. I'm not sure about the situation at St. George's right now, and I've told you I've offered the good services of myself and my associates many times to try and get these things formally organized, but I think you can probably. I've always had an interest in the factors that that promote and that hinder the dissemination of new technology. One is, if you can't make any money from it, it's difficult. And these scans are not a money spinner. So nobody's going to earn a lot of money from it, which means that's one motivation missing. The second is, if a new technology fits in well with the zeitgeist, with the with preconceived notions, with the strongly held convictions of decision makers, then it's gonna go like wildfire. If it's the opposite, if the new technology is disruptive in that it goes against what decision makers believe, then it's going to take much longer. It's a common phenomenon. It's a hobby of mine. I could talk about it for an hour I want, but that's the way it is. There's not a lot of motivation out there, and the motivation these days comes mostly from patients. I mean, I get emails from all over the world, and then I tell them, well, actually, I think there's somebody in Gothenburg who does this, or I think there's somebody in Sheffield, or there's somebody in Munich, or in Baltimore, or in Houston, Texas. It's this. Okay, here in Sydney, we're actually blessed because there are several locations where you can get that imaging. It's not like that in London. There's exactly one place in all of the UK that does this properly, is in Croydon. And they're totally there. It's an NHS setup, so you can imagine what it's like.
Should GPs be educating our patients about the evils of forceps?
Actually, the previous question I haven't quite answered. Okay, you see somebody at 6 weeks, and she's fine. That's all right. Do you need to do anything at all? Probably not. But if she's not fine, or if she's had risk factors, so anybody who's had her first baby over the age of 32, anybody who's had a forceps, anybody who has had shoulder dystocia, anybody who's had a 3rd-degree tear, anybody who's had a huge baby, that kind of thing. I mean, you see, of course, you see women like that all the time. And then I would encourage you to examine them. Examine them. Because really all you need to work out whether something's badly wrong is your fingers and your eyeballs. So if the perineum is supposed to be, 4 centimeters or so, 3-4 centimeters. If it's only 2, and if there's a bad scar, well, something happened. And if the vagina is gaping, that's not normal. And if you really want to go the whole hog, you get yourself a plastic or a wooden ruler. You can use a tongue depressor with marks on it. And then you get the patient to do a Valsalva. The distance from the urethra to the anus is supposed to be 7 centimeters or less. In some, it'll be 10 or 11. Then something's badly wrong, okay? And of course, you can examine digitally. Could you please show my face? Are you showing my face? Because then you can see this. This is our palpation model. That's the outside. That's the vulva. The clitoris is up here. The anus is down here. That's the vulva. 1.5 centimeters up is that V-shaped muscle that you saw on my images. You can examine it digitally. It is not difficult. You put your finger in. You feel for the urethra here. It's a wiggly tube. And the bladder neck's higher up. So there's the urethra. That's the bone of the inferior pubic ramus here. That's the bone of the ramus here. And then you get the patient to contract. In a healthy patient, in somebody whose pelvic floor is normal, there's just enough room for your finger between the muscle and the urethra. If you can fit 2 fingers in there, something's wrong. if you get the patient to contract, you must feel muscle contracting on the bone in somebody who's got a normal muscle there. In this lady with a full right-sided avulsion, you will not feel any contractile tissue on the bone. It's not hard. It takes a bit of training, but it's perfectly, you don't need any fancy machines for it. So you can diagnose what we call ballooning, that is an excessively distensible levator. You can diagnose avulsion with your finger. In fact, to some extent, you can diagnose a badly repaired sphincter tear or a sphincter tear that's been overlooked. You do a digital examination and you feel how much stuff there is, how much muscle, how much tissue there is between your index finger and your thumb. Maybe that's asking a little much without formal training, but this is all within your domain. And if there's risk factors, or if the patient has problems, if she's got symptoms of prolapse at 4 months, if she's got anal incontinence, the typical thing after a sphincter tear, whether repaired or not, is flatal. Actually, often at first nothing works, and then after a few days, function slowly returns, and then what's left after 3 or 6 months is just flatal incontinence. That is involuntary passage of wind that people can't stop. Another symptom that's relatively early is fecal urgency. Having to rush to get to the loo with emotion, not being able to wait for 15 minutes. So, and if you have somebody like that, yes, you should refer them for treatment to a physio, and there's lots of very competent pelvic floor physios now. And if you're worried about somatic trauma, then you need to get imaging, and that is a pelvic floor ultrasound. Now, the next thing you said was, should we warn of the dangers of forceps? Absolutely. There's no excuse. Just read the Hippocratic Oath. It's quite obvious. And mind you, we don't swear it anymore. But if you know something that is relevant to the patient, you have to share it. There's no excuse.
Is cesarean the answer?
Mostly no. Because cesarean has got its own complications. And in some people, to do an elective cesarean is most plainly the worst idea. So if you have a 22-year-old South Sudanese migrant who's pregnant for the first time, regardless of any other factors, to do an elective cesarean in somebody who is quite likely to have more than 2 or 3 children, that's not such a good idea, because the likelihood of complication is going to go up a lot. If you have a 39-year-old who, after 3 years of IVF, is now finally closing in on term, and who would at most want 1 further baby, I believe, and I'm happy to say that before any audience, I believe that we must offer this woman an elective cesarean section, because the cards are, the odds are not in her favor. Okay, not at all. So that means that you got to talk about elective cesarean. That is the message of the Montgomery versus Lanarkshire decision. It's the message of the New South Wales Consent Manual. So, and forceps is usually the worst kind of, that's just, I mean, there's entire countries where forceps is no longer done, such as Denmark and Sweden. The Swedish equivalent of Ranskog, the Swedish college, has actually actively recommended that forceps not be used anymore. It's now several years ago. And you look up Swedish or Danish perinatal morbidity and mortality, they're better than us for whatever reasons, but certainly abandoning forceps is not going to sink your obstetric boat. That is an absurd proposition. Now,
we get to look after our patients for many years after their pregnancies.
Yeah.
If you had an older lady with fecal incontinence, colorectal or urogyne?
Okay. The short answer is, if that's all she's complaining of course it's colorectal. Okay. The long answer is, commonly these women, the average number of major symptoms that my patients have is a bit over 3. So they have urinary incontinence, they have the prevalence of anal incontinence in our clinic is about 15%. And the prevalence of symptoms of obstructed defecation is 50%. Still, of course, urinary incontinence and prolapse dominate. But if somebody's only got, if somebody of any age group only has anal incontinence, then the first port of call, actually, the first port of call should probably be a physio, a pelvic floor physio. And if that doesn't work, then I would consider referring to a colorectal surgeon with the proviso that colorectal surgeons are not, wow, now I'm going to say something really, you're probably not going to invite me again because somebody's going to complain. Colorectal surgeons are not currently in a position to provide the kind of imaging that I've shown you. That imaging is available at this point in time exclusively through gynecologists and urogynecologists. And that means that prior to referral to a colorectal surgeon, the physio, that's a no-brainer. But also, I think imaging, one could defend the position that imaging should come first, because the only reason for a colorectal surgeon to try and reconstruct the sphincter is a major degree of sphincter trauma. So if the anatomy is completely normal, then that person may be better off with a gastroenterologist rather than a colorectal surgeon. But I have to say that, of course, I'm a gynecologist. I'm not a colorectal surgeon. So when in doubt, I would defer to the opinion of, for example, John Cartmill at Macquarie, or David Lubowski at St. George's. And there's several highly competent senior colorectal surgeons at the RPA as well.
Thank you so much for your presentation. It's been very thought-provoking and much appreciated.